Very good evening to everybody. Myself, Deepti Paliwal, and on behalf of Swati Spentose Private Limited and Female Pelvic Pain Association, FEPPA, I would like to welcome you all to this diamond city of India, Surat, where we have gathered today to celebrate this wonderful evening with a live webinar on Women Pelvic Health Gynecologist Perspective in association with Surat Obs and Gynecological Society and Urogyne Subcommittee of the Federation of Obs and Gyne Societies of India. This is an educational initiative by Swati Spentose Private Limited, patron FEPPA. I would also like to inform you that this webinar has also credited one ICOG point.
Yes.
Ladies and gentlemen, now I take great pleasure to introduce a driving force behind FEPPA, our honorable founder members, Dr. Amita Jain and Dr. Vidya Bandukwala. Dr. Amita Jain is also a core committee member of GIPS. She is a senior consultant urogynecologist at Medanta, the Medicity Hospital, Gurugram. She is the General Secretary of South Asian Federation of Urogynecology. She has been served as a chairperson of Urogynecology Subcommittee, AOGD, from 2017 to 2019. She is a committee member for National Guidelines on Urinary Incontinence of USI.
Deepti, sorry,
ma'am.
I'm interrupting. You don't need to read the whole thing. It's
okay.
Yeah, it's just to introduce.
No issues. Okay.
Yeah.
No issue. Okay. So moving to Dr. Vidya. Yeah, moving to Dr. Vidya Bandukwala. She's the founder member of FEPPA. She's a core committee member of GIPS. She's an Obs and Gyne consultant practicing at Touch of Joy Women's Clinic, Fertility Center, and Saket Nursing Home and Nanavati Super Specialized Hospital at Mumbai. I would also like to take pleasure in introducing the master of today's ceremony, Dr. Kajal Mangokia, who is the secretary of Surat Obs and Gyne Society. She is a consultant Obs and Gyne and IVF specialist practicing at Orchid Hospital and IVF Center, Surat. We have Dr. Purvi Patel, who is a consultant Obs and Gyne and infertility specialist practicing at Ashirwad Hospital and Peher Hospital, Surat. With this, I request Dr. Kajal and Dr. Purvi to take over the charge of this entire session and invite our chief guest.
Thank you, Deepti.
Thank you, ma'am.
I would like to invite, thank you for the nice introduction. And I want to thank Dr. Amita Jain, madam, for giving us this opportunity today for the webinar. Thank you, madam. So moving ahead and starting with our chief guest, Dr. Tarlika Gokani, madam. It is a great pleasure to introduce Tarlika, madam. She is a senior consultant obstetrician and gynecologist practicing since 1964 in Surat. She is a past president and founder of Surat OBGY Society, founder president Dr. Tarlika Gokani Surat Menopause Health Club. She is a founder member of Surat Consultant Association, first to get ultrasound in South Gujarat. She is one of the earliest to get a laparoscopy histoscopy set up in Surat. She is a life member of International Red Cross Education, and she's done her MBBS scholarship and merit student from Lady Harding, Delhi, MD DGO from Grant Medical College, worked at KEM and Kama Hospital, Mumbai, worked at Railway Hospital before starting practice at Surat. She has served Surat since 1964, honorary at many hospitals from Maskati to Kikabai Hospital, and her hobbies are music, excellent sitar player, and a social work. So welcome, Dr. Tarlika Gokani, madam. Madam, we want to hear from you.
Hello, my dear friends. I hope all of us are in very good health. First of all, I'd like to thank the organizers of this program inviting me as a chief guest. The program formal topic related to female pelvic pain is very useful. It is an everyday practice, and many women are suffering for a long time from this chronic pelvic pain. I'm very happy to see that our society has come a long way and has progressed so well that I'm very happy with this progress of our society. I shall not take any more time. Between all the organizers and all the people who are listening to this, and there will be very, very good material to hear today. So I wish you all the best.
Thank you, madam. Over to Dr. Purvi.
Hello, I am Dr. Purvi. I would like to invite our next chairperson, Dr. Jagruti Desai, present president of SOGS. She is a laparoscopist, obstetrician, and gynecologist from Surat at Udna Hospital. She is a private practitioner at Udna Hospital Private Limited, Surat, and she is a visiting consultant at Nirmal Hospital Private Limited, Surat. Hello, ma'am.
Hello.
Dr. Jagruti Desai.
Yeah, hello. Happy evening. A warm welcome to everyone. Happy International Family Day today. To one and all, family is the emblem of unity with pride, where peace, bliss, and prosperity prevails. And I'm very happy to associate with you, all of you today. Today's distinguished speaker, Dr. Vikram Khullar, Dr. J.B. Sharma, Dr. Amita Jain, Chief Guest, Dr. Tarlika Madam Gokani, respected chairperson, panelists, senior colleagues, and dear friends. It is indeed a moment of privilege and honor for me to extend a hearty welcome to one and all of you today to this exclusive webinar on women's pelvic health, gynecological perspectives. At the outset, I am thankful to FEPPA and FOGSI Urogyne committee for making us SOGS a part of this academic session. There is a lot of advancement in the management of pelvic pain and urogynec surgeries in the last decade, and this is a perfect virtual platform for increasing our knowledge, skill, and awareness to our members first, and in turn provide utmost care to improve the quality of life and the well-being of our women. Today, we are very fortunate to have with us incredibly knowledgeable Professor Dr. Vikram Khullar, Urogynecologist from London. Thank you, sir, for sparing your valuable time. He will enlighten us with his topic on chronic pelvic pain beyond basics. We come across 20 to 30% of women in middle age who are affected by urinary incontinence, both underreported and undertreated. We have with us Dr. J.B. Sharma, FOGSI Chairperson, Urogynecology Committee, who will impart his clinical knowledge and operative skills on surgeries on SUI. We also welcome Dr. Amita Jain, a very humble person, founder member FEPPA. She will update us on cystoscopy for gynecologists. Once again, a warm welcome to all our esteemed panelists, chairpersons, to come and share their opinions and views on this topic and make this webinar interesting, successful, and an interactive one. Thank you so much. Once again, I welcome you all. Thank you.
Thank you, Dr. Jagruti Madam, for the wonderful welcome speech. She has almost introduced all our speakers and their topics also. So moving further, I would like to introduce our chairperson for the first session. You all know Madam Dr. Amita Jain Madam. She is a founder member of Female Pelvic Pain Association. She is a core member of GIBS and a senior consultant urogynecologist at Medanta, the Medicity, Gurugram. Dr. Purvi will introduce Dr. Ranjana Sharma ma'am.
Dr. Ranjana Sharma ma'am, she is a core member of GIBS, Chair AICC RCOG Division 2020-2023, Senior Consultant Obstetric and Gynec, Laparoscopic and Robotic Surgeon, Apollo Hospital, Delhi. Now Dr. Kajal and Dr. Anita Jain will introduce Dr. Vikram Khullar, sir.
Dr. Amita ma'am will introduce our...
Thank you so much for giving this kind introduction and starting this webinar in such a nice systemic way. So I will not waste the time. Dr. Khullar is here, and it's my proud privilege that we actually is having him, because he agreed for this seminar in such a short notice. So he's a very highly experienced consultant urogynecologist. He specializes in pelvic floor dysfunction, vaginal prolapse, urinary incontinence, pelvic pain, and urogynecological problems. He studied at King George, London before graduating with a medical degree from University of London in 1988. So he then went on to do the research at King College Hospital and was awarded a Doctor of Medicine and became a Fellow of Royal College of Obs and Gynae in 2007. He also works publicly for the Imperial College Healthcare NHS Trust and specializes in patients with bladder and pelvic organ problems secondary to Ehlers-Danlos syndrome. So he's also head of the Department of Urogynecology at St. Mary's Hospital in London, and actually he established this department in year 2000 there. So presently he's Vice Chairman of British Society of Urogynecology. He's an expert advisor for NICE and Vice Chairman of the NIHR. He also dedicates his time to teaching and is Professor of Urogynecology at Imperial College London. So he has got many awards and has published so many articles in the Index Journal. I am also very lucky that I got a chance to work with him in a writing group on female bladder pain syndrome. So I don't waste the time. I will hand over this platform to Dr. Khullar to start his presentation. Thank you so much, Dr. Khullar, for agreeing for this webinar. So over to you, sir.
Thank you very much. I'm just going to start the
yeah, you have to share
talk. That's lovely. And we'll go to, so in a way there are two parts to this talk. And one issue is that I'll be talking about all the different parts to chronic pelvic pain. At the end, I will talk about and I'll specifically show the technique of Botox injection to the pelvic floor, and also how to identify pelvic floor spasm. But throughout this entire vein, I'm actually going to talk about, I'll mention the newest finding that we've got, in that we are discovering a whole group of patients, it's between 5 to 10% of women who have an abnormal innate immune system. They are the same group who then develop long COVID. And we actually have recently completed a study looking at flow cytometry. So looking at the white blood cells in their bloodstream, and they have abnormal natural killer cells and abnormal immature mast cells. And there actually is a treatment for it, which we've now started. We've actually looked at the first 80 patients, and 30% are cured within 3 months. But we'll talk about it. But it actually is a key part of gynecology in terms of pain, because up till now, what we have done with pain, if we have pain with endometriosis, we excise it. If we have pain in the uterus, for example, due to adenomyosis, we do a hysterectomy. So that we have basically, when we have an immunological problem, which all of these issues are, we actually excise the organ. It's a simple way of removing the immunological problem. But there actually are drug treatments, cheap drug treatments, which we know work in these patients. But there is a problem in the diet in terms of using things like chilies, it's jeera, tomatoes, aubergines. There are various things. And if you ask these patients, they will actually tell you, oh, if I eat loads of chilies, my pelvic pain is terrible. And they will actually tell you about these disorders, but we often do not actually speak about we don't actually ask these questions. We just think, oh, that's nothing to do with medicine. But it's a complete picture. So chronic pelvic pain, there are temporal characteristics, the severity, the location. And remember, it may not necessarily just be the pelvis. It's got to be non-cyclical pain, at least 6 months duration. It may be worsened by menstrual pain, and it may be intermittent pain. It is in the anatomical pelvis, and it also may be present in the anterior abdominal wall below the umbilicus. And that's important because the transversus abdominis muscle, which is below the umbilicus, actually is innervated. It innervates the same nerve which innervates the pelvic floor, also innervates the anterior abdominal wall. And the patients may also complain of pain in the lumbosacral back, the buttock region, vulvar pain, but I'll come to why that happens in a bit. And it's between 15 to 20% of women between the ages of 18 to 50 years have chronic pelvic pain of more than 1 year's duration. And you'll notice this consistently. It's around about, 10 to 20%, and they will account for between 2 to 10% of all outpatient gynecological consultations. Now remember, this is data on Caucasian women, white Caucasians. If you look at South Asians, it's a higher percentage. In our group, in London, we have a high percentage of Arab women or women who are of South Asian origin. And there we see a much higher number. It goes up to 30%. It also has an impact in terms of fertility, and we find a higher rate in these same patients of implantation problems, so unexplained infertility. So 20% see a gynecologist, 10% will see a physician, 1% will end up being referred to a psychiatrist. Basically, it must be in your head. We don't know what's wrong with you. And the rest, no one looks after. And very few, about 75% of women, will say that they've not seen a healthcare provider for 3 months, because basically whenever they get help, people get told there's nothing we can do about this. And there is a lot which can be done. Around half will take a non-prescription drug, such as aminocetabine or paracetamol. 25% will have medications from a single provider. 12% will be put on oral contraceptives just to try and stop the cyclical pain. 61% have no diagnosis. A quarter will have endometriosis. And this same group who have this abnormal innate immune system problem, a third will have endometriosis. 49% will be non-cyclically involved, so it may be infection related, and 10% will be non-gynecological. So it's very much a gynecological problem. And between 10 to 30% will have had laparoscopies, and laparoscopy is a major reason for looking at chronic pelvic pain, and between 10% to 80% will have an abnormality. But what we're finding more and more with these patients, what you see is not what is there. So certainly in the bladder, when we look in the bladder for pain, we will find, you'll look in, it will look normal, you take a biopsy and you do a CD117 stain for mast cells and do a mast cell count, and it's grossly abnormal. We've just completed a similar study on the endometrium, and we see grossly abnormal levels of these cells on endometrial biopsies, and that's associated with infertility and recurrent miscarriage. And we are just starting, and it's only the first 5 patients where the peritoneal biopsies of these patients also have these abnormal cells. So it's a good diagnostic test, but not the toluene blue for mast cells. It's a CD117 stain, immunohistochemical stain, which should be available in all pathology laboratories. So up to 70% will report endometriosis, and if the pathology is not found, it may not be the cause of pain. And of course, between 10 to 12% of hysterectomies are due to chronic pelvic pain, and it's it has a detrimental effect in many ways. In terms of oophorectomy, these patients will often have problems with their bones. They may have osteopenia, and obviously we know the effect of estrogen and its effect on brain function. So chronic gynecological causes, huge list of causes, and it goes on, infection, inflammation, there are many reasons. And there may be psychiatric, psychological causes, but we're now realizing that these patients have an abnormal microbiome in their gut. The gut bacteria become abnormal, and that's a major reason for abnormal causes such as depression. The patients will often complain of anxiety. They'll talk about tachycardia, problems with their blood pressure. They stand up and their blood pressure drops. And this is an abnormality of autonomic function. And obviously you may well see, but I would say the patients who have hypochondriasis, opioid seeking, it's actually very small. And often they will tell you, if there's something wrong with their psychology, they'll say, I have got a psychological problem. They will tell you that. It's not that they tell you they've got a gynecological problem and suddenly psychology is an issue. And then a vast majority of these patients will have something called fibromyalgia. And this just tells you that it is a systemic problem. It's a systemic problem of inflammation in the body. And they will often have functional bowel disorders. So they'll have irritable bowel. And again, there are studies looking at irritable bowel, and the biopsies of the gut show increased numbers of mast cells in the bowel. Or they may have inflammatory bowel disease, and we see a microcolitis associated with this disorder. There is a 20 to 30% higher rate in the same group of polyps and bowel cancer, and they will often complain of chronic appendicitis. When it's removed, it will be inflamed, not strictly an appendicitis, appendix which needed removing, but if you stain it, you'll find again the same inflammatory problem. And urinary, they may have interstitial cystitis, urethral syndrome, much higher rate of Drusen activity, and we know among Indian women there is a much higher rate of detrusor activity. It's double the rate of Caucasians. And obviously chronic calculi. Other issues, hernias, disc disease, arthritis, but these are all related to joint hypermobility, which is associated with this abnormal innate immune system. And then obviously in terms of psychiatric, depression due to pain may not be uncommon, and mood is a major modifier of the way people see their pain. And so if you have somebody where that is a problem, getting it treated will often help the perception of the gynecological pain. And fibromyalgia, it's between 2 to 4% of individuals, and 80% of these women will have it. And it's an abnormal processing mechanism in terms of the autonomic nervous system. And you have heard me talk about the autonomic nervous system repeatedly. And the criteria that there's pain in all 4 quadrants of the body and axial skeleton, and that they have 11 of 18 defined tender points. And the tenderness is due to an amplification of pain signals. So these are the points, and that the patients, 11 of these 18 points, they have pain. And notice, it's not just in the pelvis, it's in other parts of the body. And often patients will tell you, I have fatigue, I have this pain all over my body, and I've also got this pelvic pain. But at least by being a gynecologist, you can bring everything together. And they have increased visceral sensations, abnormal visceral sensations, and it's associated with abnormal motility, such as irritable bowel. And they will often tell you they don't sleep properly. It's a terrible problem. And one of the treatments, ketotifen, which is a very old drug, it's for asthma for children, actually. It's about 40, 50 years old. And ketotifen is given at night, and it corrects the sleep disorder, and their energy levels improve. In terms of interstitial cystitis, the patients may have urgency, incomplete bladder emptying, and we may see mucosal lesions. And some of these patients will actually have abdominal pain. And we may see this is a Hunner's ulcer, and as the bladder is filled, the bleeding starts around the edge of the ulcer, and it's important that when the bladder is filled, that it is filled and that the pressure of 100 centimeters of water is maintained for more than 3 minutes, and then you'll see this bleeding occurring. And also we may see this, we may see bleeding. If you see trabeculation, that's associated with overactivity. There's a study which shows that 90% of these patients have detrusor activity. But the key thing is, in patients with bladder pain, we'll see this hemorrhaging and it bleeding from the wall. It's important, it must be done 2 times. If you fill the bladder and then leave it, you won't see it. You empty the bladder, refill, and then you'll see the hemorrhages appear. Okay, so the patients may have urethral syndrome, may have irritable bladder, may have lower abdominal pain, which may be a chief presentation. Gynecological causes, obviously endometriosis, as I've said, but remember, endometriosis is an inflammatory condition. There is an abnormal gene relating to inflammation and endometriosis. All women have retrograde menstruation. It is the immune system which defines the abnormal immune response to the menstruation. And it's around a quarter, by laparoscopy, you see in about a quarter of cases with infertility or chronic pelvic pain, but overall it's estimated to be around about, I would actually say it's more 10% of women of reproductive age. And it can be non-cyclical, associated with pain on intercourse, pain with painful periods. And these peritoneal implants, they secrete inflammatory chemicals, and therefore the endometriosis itself does not, the amount of endometriosis does not relate to the pain, but this is due to it being an inflammatory problem rather than it's actually the physical piece of endometriosis. And obviously the key thing is to destroy the endometriosis itself with diathermy. And vaginal endometriosis can be associated with dyspareunia, and there's also increased prostaglandins found in these patients. It may be a normal examination. Obviously, the key is to do MRI of the pelvis to look for endometriosis, but we're looking for that retroverted fixed uterus, tenderness of the uterosacrals, and obviously pelvic masses. Adenomyosis, well, it's supposed to be thickening of the uterine wall. It's supposed to be where the endometrium goes into the wall of the uterus. And again, it's an inflammatory condition. We know that there are histamine type 2 receptors found in the uterus, and therefore blocking them with, ranitidine we don't have anymore, but cimetidine, famotidine, nazatidine will actually help this. So you do try to stop the cycles, but in a woman who wants the cycles because of infertility, then famotidine is a very useful medical approach, but unfortunately, the only surgical approach is hysterectomy. Uterine fibroids, well, it's really pain is due to degeneration. We have done a study looking at the number of fibroids in the uterus, but really the uterus has to be more than 12 weeks size for it to have an impact in terms of bladder function or bowel function. Obviously, hydrosalpinx, if you've got an infection in the pelvis, it will cause pain. And when we look at laparoscopy findings, you can see that it varies very markedly. This is looking at normal patients, percentage of normal patients on the left-hand side, compared with patients who have adhesions, compared with patients who have endometriosis. And it really varies according to the interest of the author. Now I'm going to do a quick one on pelvic floor spasm. This is very new. There are multiple studies on this, and this is characterized by an increase in pelvic tone. The important thing is that it is pain on digital examination, laterally in the vagina, 3 centimeters from the vaginal introitus. And it is present in up to 85% of women with chronic pelvic pain. And basically their muscles do not contract. And when you compress the pelvic floor, they'll go, oh, it really hurts. And you'll see the patient flinch with pain. And it will be the pain that they notice on intercourse. And it is normally the result of another organ in the pelvis, be it bladder infections, be it interstitial cystitis, be it endometriosis, be it something to do with the bowel, irritable bowel. And the pain radiates from the pelvis to can be down the anterior surface of the thigh, this is the obturator nerve. Sitting will exacerbate the pain, and you'll see the patient sitting on one buttock. You'll look at the patient and they'll be sitting on one side, and you say, why are you sitting on one side? Why don't you sit properly? Well, it hurts to sit. And it is made worse by vaginal intercourse. They will often talk about pain in the sacroiliac joint, and then we get urinary symptoms of hesitancy, retention. They will quite often have obstructed defecation. So when they try and open their bowels, the colon doesn't empty. And you can look with vaginal pressure measurements. At the top, we can see, this is from Fitzgerald and Casatis from Chicago, that when the patient contracts their pelvic floor, we see increases in pressure, but a patient who has spasm of the pelvic floor, the contraction wanes as they contract because they get more and more spasm, and you don't see an increase in pressure. And on MRI, you can see that when they contract, here we got an MRI at rest, and you can see the sacrum and the coccyx here. And when the patient contracts the pelvic floor, you see an increased angulation. But in a patient who has pelvic floor spasm, it's always like this. At rest, the coccyx is pulled forwards. But you can also, on examination vaginally, you can feel the spasm itself. And also the piriformis, obturator internus, obturator externus also get involved, and patients will talk about pain in the hip joint as well. And the common places are obviously levator ana, the pubaric talus muscle, going out to iliococcygeus here, and isococcygeus here, and obviously in the coccyx itself. And patients can do physical therapy, so actually bringing the knees up to the abdomen will help. Abducting the legs will also help, and also 2 milligrams of diazepam taken at night will also help the spasm. But how do we actually help these patients? These patients are desperate. They want treatment. They want it to be gone. And one way forward is Botox. Botox, we know, gets rapidly taken up into the muscle and the nerves around the muscle. The way that neurotransmitters work in the nerve, and it's the sensory nerves, is that these the SNAP complex forms and acetylcholine is released, activating the muscles. With Botox, Botox enters the nerve cells and stops the SNAP formation. Therefore, the vesicles can't be released. It's also a neurotoxin, so the nerves die and go back into, they die back. When they regrow at a normal level, because pain increases the number of nerves. So important, Botox, it is not empty. When you see the bottle and it looks empty, it is not empty. People throw the bottle away because they think there's nothing in there. There's such a small amount, you can't see it. I always use bupivacaine 0.5% because it's nice to get some local anesthetic working, and at least the patient gets relief for 18 hours post-procedure. Patients may do it under sedation, under general anesthetic, or they may even do it under local in your clinic. So how do we inject? It's a green needle. We will normally use 20 mils. And the most important thing is to put the finger into the vagina on the lateral surface, not push back on the posterior fourchette. Unfortunately, we had a registrar who used to do that, and then the patients ended up with fecal incontinence, because as soon as you push backwards, the rectum comes forwards and you inject straight into the anal sphincter. So it's a lateral injection on the vagina. The needle is inserted first, because if your finger's in the vagina, you stick the needle straight into your finger. It's inserted under the vaginal skin. Then the finger guides the needle into the pelvic floor, and on each side, 10 injections are carried out, each of a mil. And you try and go as high as possible on each side. This is poor technique. Pushing on the posterior fourchette brings the rectum forwards. That person's injecting to the rectum. They're not injecting the pelvic floor at all. That will cause complications. So are there studies on this? Multiple studies, small numbers ranging from 1 up to 60. And basically they were used for a range of symptom improvements. And the dose ranges from 10 units, which I really don't think works particularly per unit. Overall, it's around 200 units. There's an excellent randomized study where 60 patients were randomized to placebo or Botox. And what we see is, this is the Botox line here in black, and the constipation, rectal pain, it's where somebody's injected right into the rectum. You can paralyze them if you do that. We do actually we inject through the buttock, put your finger above the pelvic floor and inject into the pelvic floor that way. So in conclusion, pelvic floor dysfunction can lead to dyspareunia, pain on intercourse. Assessment is complex, but there are validated tools, and the treatment can be physiotherapy for pelvic floor spasm, but often it's a long-standing problem, and we've got to really even though the manufacturer says dilute in saline, I use bupivacaine, and it's 0.5%. And then it is 1 ml, so it's 10 units per injection site, and it's 10 sites per side. If you want to see more about this, I think there is, because it also, this disorder, it causes bladder pain. There is a talk by me on YouTube. So if you look up my name, and you can actually see a talk there, and it'll explain more about this innate immune system, and also the dietary changes which we request patients. So we will often say to patients, we don't want them to eat chocolate, to have tomatoes, oranges, pineapple, kiwi, and obviously chilies and jeera. So there are these funny things, and they all cause inflammation in this group of patients. And often you can ask the patients, do they get very severe reactions to mosquito bites? And often they'll tell you a story about they've had a bite from some kind of insect or a spider, and it was so bad that they needed antibiotics because it was a really severe reaction. And this is just telling you that their immune response is actually abnormal. It protects them, but perhaps sometimes we can get too much protection. And that's what we're seeing with COVID, with the increased urinary tract infections, increased pelvic pain. We're seeing a lot of those sort of problems now with COVID.
Ma'am, are you taking, there is one more question from Dr. Shailesh Rena. Dr. Ranjana, would you like to take this question? Can you see, ma'am? So it's, how long does the effect of Botox last for pelvic pain? It's from urologist, renowned urologist, Dr. Shailesh Rena from India. This is the question.
Yeah, so the most important thing to say to the patient at the beginning is that when the injection is put in, the local anesthetic will last for 18 hours. So at least the patient can go home, they'll be comfortable. But then after 18 hours, the pain will return immediately. And they must not be worried about that. The Botox will start working after 6 days. But it's very reassuring if you see the patient after the procedure and they say, the pain is now gone, I feel so much better. Reassure them that the injection has then gone into the correct place, but not to be worried when the pain returns the next day. Then the Botox will start to work and the pain will gradually get better over a period of 6 weeks. And then at that point, that is the maximum benefit, is at 6 weeks. And then it continues between 6 to 9 months. Now, when we evaluated over 200 patients with this, we found that 90% did not need a further injection. And that's because the nerves remodel and then they don't need it. But a certain proportion of patients by 6 months will come back and say, the pain's come back, please can I have the injection? It just made such a difference to their lives. These people can walk again, they can sit normally, they can live their lives. So it makes a huge difference in quality of life.
Thank you so much, sir, for this such a nice explanation of the question. There is many more questions. One is that, can pelvic floor spasm cause constriction ring in vagina?
Exactly. You feel a constriction ring, and when you press on it, if it's scarring, if it's fibrosis doesn't hurt. But when you press on a muscle which is in spasm, we know that, if you get pain in your neck, how many of us have woken up in the morning with pain in our neck? And if you press on the muscle, it hurts. But if you press on a muscle which is in spasm and keep pressing, eventually the muscle relaxes. So if you wanted to discriminate between scarring and muscle spasm, so long as the patient is comfortable, press on it, keep pressing, and after 30 seconds, it will start to relax. But don't be surprised if the spasm comes back. But that's how you can discriminate between the two.
Thank you so much, sir. Another question is there any other option rather than botulinum toxin which can be tried for the same thing?
Well, the certainly 2 milligrams of diazepam, and basically that can be taken up to 3 times a day. We find some patients talk about, I don't know if cannabis oil is allowed in, I don't know, in India or not, but that's just the pain relieving side, and it relieves muscle spasm. Injecting a mixture of depomedrone, 80 milligrams, with 10 mils of, it'll be a long-acting local anesthetic such as bupivacaine or marcaine, into the pudendal nerve could help, but really, and obviously using physiotherapy is the other one. But these are stretching exercises, not pelvic floor exercises are the worst. They make it much worse.
Yeah, thank you, sir. One question is, can posterior colpoperineal cause this spasm?
Right, okay. Now, with posterior vaginal repair, the one thing we do not do, you know, the old teaching was that the support to prolapse is like an arch, and if you can make the stone at the bottom, the foundation stone, strong, then it will support the prolapse. So there was the teaching to do a perineal stitch, which was anterior posterior, to basically close off the vaginal introitus, but also to try to plicate the levator ani muscle in front of the rectum. Now, we will never do that. In fact, we often will not. Well, to be honest, we don't actually remove the vaginal skin. We use the vaginal skin. You know, if you think about a curtain, when a curtain is closed, the curtain is thin. We have this amazing skin which has been stretched by the prolapse, and if you pleat it, you can actually produce a thick structure. So we will do that, and then particularly around the perineal body, we will do a Nichols stitch, an Nichols. So it's the grandfather of American urogynecology, the Nichols stitch, and then you don't get dyspareunia, but we will not plicate the levator because you will just cause pain. And that's where, if you look at the Stuart Stanton paper on dyspareunia, they had a 30% pelvic pain dyspareunia rate after posterior vaginal repair. So go for the Nichols stitch for the perineal repair. And yeah.
There is no stoppage of questions. We are getting a lot more. If you are having time, that we can ask, sir.
Sure.
So another question is that exactly what cocktail do you use for bladder pain syndrome for bladder installation?
Right.
And how do you prepare it?
Okay, we know the bladder installations really have their foundation in the US, and there are 2 groups. There's the West Coast and the East Coast of America, and they both have completely different traditions. The East Coast, so New York particularly, they will add gentamicin, 80 milligrams of gentamicin to their bladder installations. On the other side, you have the group in California who would use heparin. So they would use heparin with an alkalized lignocaine. So what we try to do is we put the 2 traditions together, because, you know, they can't be totally wrong. They must have some truth in both groups. And if we're going to put something into the bladder, we put the best cocktail. So certainly the one we would use is Iaril, I-A-L-U-R-I-L. It contains chondroitin sulfate and hyaluronic acid, because those seem to be, you can get 2 types, and this one has both. We will add 10 mils of 1% lignocaine, 10 mils of 8.5% bicarbonate. So we're using that alkalized lignocaine mixture. And then we will add 80 milligrams of gentamicin. Now, and then we will put the installation in. It's very well tolerated. much better than DMSO. DMSO, it's so difficult because it does cause pain in quite a proportion of patients. And the patients keep that cocktail in their bladder for 2 to 3 hours. If you find in the first 2 installations, which are a week apart, the patient had a remarkable improvement. Pain was much better, everything improved. But then with the 3rd installation, things start to get worse. Look for infection, because quite often these patients will have a biofilm, and we've recently completed a study looking at squamous metaplasia that you find on the base of the bladder. So that white crust, it almost looks like sugar on the base of the bladder, and that is a biofilm full of bacteria, and it causes recurrent bladder infections. And often with an installation, you put the installation in, calms down the inflammation, then infection comes out, it all goes backwards. So just watch out for that when you're using your installations.
Okay, thank you, sir. I think we are also having some constraint of time, but last question, which is I think relevant to present situation from Dr. Jain, that is, do you have any treatment for chronic pelvic pain patients with long COVID fatigue?
Yes, absolutely. As I said, we had completed this 100-patient study looking at long COVID. Literally all their blood results were normal. There's a slight increase in serum tryptase. It's slightly, it goes around the level of 8 or 9, but otherwise everything else looks normal. We use a combination of loratadine, which is a type 1 antihistamine. So you can use any type 1 antihistamine that is available. We will use a slightly higher dose than the regulated dose. So antihistamines, you have a big leeway. So we will use 10 milligrams twice a day. After a week, we would introduce ketotifen, which is it's a slightly drowsy mast cell stabilizer and leukotriene inhibitor. Very old drug. It's used for children's asthma. I can guarantee it will be available. And you start on 0.5 milligram at night. After 8 nights, they increase to 1 milligram at night. And then the last tablet to introduce is famotidine. In the States, it's called Pepcid. It's off patent, it's widely available, and we will use 40 milligrams a day. Within a month, the patients will tell you that their brain fog has gone, that their muscle pains will still come and go, because the problem is the innate immune system varies, but they will gradually, their fatigue will disappear. And by 3 months, it will be gone. The reason for using famotidine is that famotidine stops the re-entry of COVID into human cells, because it's actually been found, you'll see there are recent case reports where patients have done colonoscopies, and on biopsy of the bowel, COVID has been found up to 9 months after the original infection. So it's it's a bit like retroviruses. We're seeing these viruses persist in the body, and it's a persistent innate immune response. So you'll notice, and it does work, but watch out for an infection either in the bowel or the bladder. If they've got an infection, their symptoms, certainly in the bladder, the pelvic pain will not improve. And we're seeing urinary tract infections with Klebsiella, Morganella, Serratia, things we have not seen before. And it's just the immune system has gone crazy.
Oh, thank you very much, Mr. Khullar. It was a great talk and quite a bit of insight, a new insight into it. You know, women will really benefit if we have a wider outlook when they come to us with a pain. And majority of us just try to dismiss them, because once there is no obvious gynecological problem detected, that's it, you know, we can't go further. But you see now microbiota, molecular basis of pain, and there's so much into it. And if you really, you are keen to find the reason, you will be able to find a cause and then help these women. So thank you very much. It was very, very good, talk. And we would like to have you more often on this platform, because nowadays, this is the only rescue for us in this pandemic, having you so easily, and on the virtual platforms. So thank you very much once again. And Amita, back to you.
Yeah, thank you so much, sir. I think there are a lot of queries left, and if you are having time, then you can actually answer them directly online, or otherwise we will convey those queries you to answer it later on. So you can.
Great pleasure.
Thank you so much, sir. I know you are engaged and you have to join another webinar. So thank you so much for your kind presence, sir. Thank you. So we can proceed now. Kajal, over to you.
Yes. Amita ma'am, just I want to share one thing with Dr. Khullar. Sir, I am doing a cosmetic gynec practice and I am getting excellent result in the cases of vaginismus with the botulinum. So one of the distributor had given a call to me that the ampule is empty, ma'am. So when you receive the ampule, whether this vial are filled with the drug or they are empty. So that was an excellent slide. Sir, you had shown that this is not empty. So it was a very nice, informative lecture, sir, by you. Thank you so much, sir. Now,
yeah, you can move ahead. Yeah.
Now,
yes, please.
So moving towards the next session, that is surgeries for SUI by Dr. Sharma, sir. I would like to invite our chairperson for the same. We have Dr. Narendra Vaghela, sir. He is a senior gynecologist at Aneri Hospital, Surat. He is a past president of Surat OBGY Society and a certified IMS menopause practitioner. Sir, you just personally, I want to say, sir is a very simple and a humble person, and he has supported us and guided us in this program for arranging this webinar. Thank you, sir. Welcome, sir.
Our next chairperson is Dr. Ruta Gokani Rao. She is a consultant obstetric and gynec at Ruta Multi-Speciality Hospital, Surat. She is also a laparoscopy surgeon and infertility specialist. And she is also our past president, SOGS. Welcome, ma'am. Dr. Ruta Gokani, ma'am, will introduce our next speaker, Professor Dr. J.B. Sharma, sir. Ma'am, over to you.
Yeah, thank you. There's some echo going on. So it's my great pleasure to introduce our next speaker, Dr. Professor J.B. Sharma.
Ruta, ma'am, you need to switch off your another device. I think it is 2 devices are on nearby you.
Let me check. Just mute. Okay, now am I audible? I'm so sorry. J.B. Sharma sir is the chairperson of the Urogyne subcommittee of FOGSI. He's the professor of Obs Gynaec at AIIMS, New Delhi. And he's worked extensively at St. Bartholomew's Hospital, Homerton University Hospital, and Whipps Cross University Hospital, all at London. He's also been awarded the B.C. Roy Award by the President of India. He's the chief editor of the Indian Obs Gynaec Journal, as well as the Journal of Pediatrics. And he's also won the ICMR Research Amrut Modi Award for research work in anemia in pregnancy. So I welcome you, sir.
Thank you very much, madam, for your kind introduction. And at the outset, I congratulate Surat Society, Madam Yogeshwar, and Amita, Jain, Ranjana, Sharma, and everybody. Really congratulations that we could rope in Professor Khullar, his lecture was excellent. So I'll be subdued in front of him, but I'll try to do justice to my topic. And my slides will be presented from that end of the chest. Yeah. So really, it's a real pleasure to come, though virtually, to Surat. Surat has been a favorite place for all of us, and I'm sure all of you are doing well. So next, can we have the next slide, please? So yeah, so we all know that stress urinary incontinence has been defined by International Continence Society as the complaint of any involuntary loss of urine with activities causing increased abdominal pressure, like sneezing, coughing, laughing, climbing stairs, sporting activity. So in other words, simple word, basically any raised abdominal pressure causing leakage is called SUI. Next, please. So we have, so diagnosis is, and basically there may be confusion between stress incontinence and urge incontinence. In urge incontinence, basically there is urge to pass urine or overactive bladder syndrome. So I won't go into detail of that. I'll restrict my talk to the stress urinary incontinence. That means increased abdominal pressure, coughing, laughing, sneezing, making air. So normally the traditional management is like, we initially start with non-surgical treatment and the lifestyle changes. And this will be common for overactive bladder syndrome and SUI. So that means weight reduction, avoid tea, coffee, smoking. So all of us know that what are our bladder irritants. Like for me, it may be coffee, it may be tea for someone, it may be coke for someone. So we should restrict too much of fluid intake also. And then physical therapy, Arnold Kegel started exercise as earlier 1948. So Kegel's exercises. So all of us should do perineal flow exercises. Professor Abdul Sultan from UK says that either you use it or you lose it to perineum. So we have to do that perineal flow exercises. So roughly, I advise to my patient twice a day, 15 minutes each time. So they can try to pass urine, hold on to it. They can pass, mostly hold on to it. And I was in UK last year, King's College London. So they were doing, asking the patient to do deep breathing exercise, like yoga exercise, which we do. So when we take deep breath inside, diaphragm goes down, abdominal contents go down, they test the perineum and perineum contact. And then when we breathe out, perineum, will go up. So we, in other words, with each breath, we can do contraction of the pelvic floor muscle. That is also a basic exercise. Bladder training is timed passage of urine. That means initially first week patient does it every, okay. Oh, sorry, can we?
Yes, sir, you're visible.
Can you see me now? Huh?
Yes, yes, yes.
Okay, and then, yeah. Can you see me? No, sorry. Okay, so then so we have like, bladder training, also in that time passage of urine. So we have to advise the patient, maybe initially we can start with 2 hours in first week, then we increase by 50 minutes every time. And then drugs are basically there. The drugs don't really work that well in case of stress incontinence, but duloxetine, which is an SSRI, serotonin reuptake inhibitor, 20 milligram a day, maximum can go up to 40 milligram a day, can be tried. And the various devices have been introduced like Introl, Quantiform and all, but to be honest, they don't really work very well. Similarly, the pessaries also may work with prolapse, but not very well. But like you can try them for short time during pregnancy or etc. also, or before patient is waiting for surgical treatment. Similarly, bladder drill, biofeedback. Bladder drill, other name of bladder training also, and biofeedback, that means exercises. So these can be tried, basically behavior therapy, alpha agonist, neuromodulation, hormones. Hormones, estrogen therapy may have some role, topical estrogen therapy. There is basically local atrophy of the vaginal mucosa. So this was just to complete the list. To be honest, main treatment remains surgical treatment. But before first, like at a routine policy at AIMS, for first 6 weeks, all patients are tried like, weight reduction, decreased tea, coffee intake, decreased fluid intake, exercises and all. And then we assess the patient after 6 weeks to 3 months. And after 3 months, I ask the patient, if she's happy, she says, Dr. Sharma, I want to try more. Then I continue the pelvic floor exercises, I continue with the bladder training, I continue with duloxetine therapy to her. We can easily go up to 2 years with this. In my experience, it works very well in mild to moderate incontinence, but usually moderate to severe incontinence will require some surgical treatment. Next slide, please. Okay. So, yeah. So all women basically should be offered non-surgical option first. Never do surgery in the first week itself. It's reserved for women who decline or fail non-surgical therapy. But to be honest, for moderate to severe incontinence, usually surgical treatment will be required. But for first 6 weeks to 3 months, always try, non-surgical treatment in the form of duloxetine, pelvic floor exercises, bladder training, and decreased tea, coffee intake, etc. Next, please. Okay, so these are basically, and then so various operations. The first operation started was MMK operation, that was colpo suspension. In that case, basically the paravaginal tissue was tied to the pubic symphysis. So that operation had a wonderful results, but unfortunately, up to 5% patient will have, osteitis pubis, which can be a serious condition. So that's why birth then came with the operation, and then we can do birth colpo suspension, and other operations that we'll be discussing birth a bit in more detail. Then laparoscopic retropubic suspension, vaginal anti-repair, anti-colporrhaphy or Kelly's repair. I want to discuss because many of our senior gynecologists have been doing it, and even I've been doing it along with third-degree prolapse. So many of our elderly ladies have got third-degree vaginal prolapse. Along with that, they have got incontinence also. And if they have mild to moderate incontinence, so at the time of vaginal hysterectomy, when we are doing anti-colporrhaphy, we can take, like, we put a Foley's catheter, inflate it to 5 ml, and then we take 3 stitches, one slightly above the level of our inflated bulb, one at the level of the bulb, and one below that. So 2 to 3 stitches with 20 to 30 vital we are taking on either side, plus in the at the bladder serosa. So this will cause called Kelly's repair, and you keep the catheter for about 72 hours. So this has about 50% relief rate. But I mean, to be honest, if patient has got moderate to severe incontinence, then I tend to do vaginal hysterectomy along with the TVT or TOT in these patients. Then the suburethral slings, I mean, including traditional suburethral slings and minimal invasive sling operations, which we'll be discussing. Needle suspensions were in vogue when I was in UK. 92 to 96, my consultant used to do STEMIs operation, in which they used to do endoscopy, cystoscope, along with they used to put the STEMIs, with the STEMIs needle on either side. But unfortunately, I mean, the results are not that good to take continuously. Prera, RAG, STEMI operation are not very commonly done these days. But burst colpo suspension, I mean, open or laparoscopic, we are still doing it. Next, please. Okay, so these are other basically operation and the grade of recommendation. Tension-free tape, grade recommendation. Transoperator tape, again grade A recommendation. So I know Amita Jain uses a lot of tension-free tapes and all. A single incision mini sling are I mean, I don't use personally because results are better with standard TVT and TOT. And then facial suburethral sling has come back into vogue now. We have done its thesis also. I'll be showing some slides also, because there has been some confusion about the mesh erosion, which we'll be discussing. And then open abdominal retropubic colpo suspension, that means burst colpo suspension has got grade A recommendation. Laparoscopic retropubic colpo suspension, that means laparoscopic burst gain grade B. Anti-colporrhaphy D. Needle bladder neck suspension D. So if you see, that's why anti-colporrhaphy Kelly's repair and needle bladder neck suspension STEMIs, etc. they are D. So they are not really done. And peripheral injection of bulking agent is pending approval. And artificial urethral sphincter basically can be done in selected patient, but the cost is prohibitive. It is about 7 to 8 lakh rupees and not really available in India. So I won't go to discuss that. I mean, that is basically beyond us. So basically, I mean, we are using either tension-free tape, which can be standard TVT, it can be standard TOT, or like, burst colpo suspension and the rectal sphincter sling surgery, which we have started. So in other words, and I recommend the house that let's learn 1 or 2 good operations and use them more often. Then we become more expert in them. So initially, I started like burst colpo suspension. I do open by mini technique rather than laparoscopy, but laparoscopy can also be done in safe and it's very safe. And then I started to do TVT, standard TVT, but then there is a risk of bladder perforation that, so then I switched on to transoperator tape, and I still do it. But there is maybe some problem of availability in near future. So then we did a thesis on rectal sphincter sling, and we are using that also now. So we can offer to our patient burst colpo suspension, to some patient TVT, as well as rectal sphincter sling surgery. So then we can, so we have got now in our basket 3 of good operations we offer to our patients. In fact, last year I was in King's College London, and I went to learn, but after the TVT is no longer available in UK, and I was asking, so they have forgotten how to do burst colpo suspension because they were not using it, and they haven't yet picked up the rectus sphincter sling. So they were in fact unable to offer anything to the patients other than doxycycline therapy or these pelvic floor exercises. And in fact, when I asked them that I want to learn some what you are doing now, they say, Dr. Sharma, will you teach us rectus sphincter sling or burst? So I was laughing with them. So actually, like touch wood, I never stopped doing burst colpo suspension in India because those patients who couldn't afford tapes, I was using burst. So that has a definite scope. And then we had learned rectus sphincter sling also, so we can offer something to our patients. Next, please. Okay. So this is the basically initial evaluation of the patient is very, very important, and then we can offer them surgical intervention and ask. So I presume now we have tried 3 months therapy to the patient of fluoxetine, pelvic floor exercise, and patient has come back to me. She wants definitely, she's not helped by that. She wants definitely surgery. That means patient has moderate to severe incontinence. So we need to take the detailed history, physical examination, objective demonstration of SOF, and you can actually assess it. You can do urodynamic studies basically. Though American College and RCOG, they say if it's a pure stress incontinence, you can do surgery or sling without doing urodynamic studies. But I leave it to you. Maybe Amita can answer that better. Should we do routinely for all patients? But I mean, though we tend to do, we have got available, but that costs money, and sometimes so it's not a mandatory to do urodynamic for all patients of stress incontinence. But maybe from a medical legal point of view, and especially for more complicated cases, we must do urodynamic studies as a baseline, and it will help us also later on for follow-up the patient and in case of any medical legal issues. Next, please. Okay. Okay, so these are the basically mixed, like these are the conditions where you have to do urodynamics in any case, like patients complicated surgery, previous failed surgery, or mixed urinary incontinence, and or like otherwise, I mean, and next please. So, and this, so proper history taking is very important. Never, I have got patients like, once a gynae consultant has brought her mother and she made the patient to lie on my table and she said, Mama coughed, and there was leakage of urine. And she said, Sir, Dr. Sharma, you just do RTOT on my mama, and I said that when I examined, I could feel the bladder, and then I, I was not convinced, and there was 500 ml in the urine in the bladder. So had I put a tape in her case, it would have been a blunder. Similarly, one of our professor of microbiology, she admitted her mother and got a tape also. And then I realized that she was having neurological problem. So, you have to please resist this. I mean, sometimes your own colleague bring the patients and they make the diagnosis themselves. So always assess the patient yourself. Never be in a hurry to put the tape or do birth colpus on these patients. And only in suitable judicious patient we should do. So we have already discussed that MMK operation, that pubic symphysis, but it's not done anymore because it can cause osteitis pubis. So same thing, birth colpus suspension, birth basically modified it. That means we are taking stitches in the, on the paravaginal tissue adjacent to the bladder neck, but not into the bladder or urethra. And then we tied them to the ipsilateral iliopectoral ligament, Cooper's ligament. I'll be showing you the slide. And then the paravaginal tissue after tenderness, you can use vaginal obturator self, obturator fascia. But I tend to do birth colpus rather than other these operations. Next, please. So birth colpus suspension is one of the gold standard treatment, and this is the basic picture of the birth colpus suspension. So this says 4 permanent suture, but I put 2 permanent suture. I mean, so that will total on 2 on either side. So what I do, patient is put it on semi-throttling position, assistant standing between the 2 thighs. We inflate the, we put a Foley's catheter, inflate the bulb to about 7-8 ml, and then from above I open the abdomen by transverse incision, little bit below the standard phenol, and I tend to give about 5 to 6 centimeter incision. You don't have to be 10 centimeter, 5, 6, and then from below my assistant lift it. So I, don't open the peritoneum. We work in the cave of adjacent of the pubic symphysis without opening the peritoneum. So now my finger, I can feel the bladder. I can feel the bladder neck by the inflated bulb, and I can feel the bulb. So the catheter. So catheter is urethra. Inflated bulb is bladder neck, and my assistant is pulling it out gently from below, so that's not lying loose in the bladder. Otherwise, you may take stitch by mistaking the bladder. So now it is very clear that inflated bulb is bladder neck and the catheter is urethra. So now, and my assistant lifts the one fornix for me, say initially left, and then I take a deep bite with either nylon or Corolline suture number 10. So just very close to the bladder neck, but not in the bladder, not in the urethra, but very close to the vagina and not up to the vaginal mucosa. So thick bite, but not up to vaginal mucosa. I take 1 stitch, then I just take another stitch adjacent to that, distal to that on left side, and then same procedure I repeat on the right side. And I don't take in the Cooper's ligament at this level, because if you take in the Cooper ligament, then you won't be able to take the second stitch. So I waste that with 4 sutures. So 2 on left side, 2 on the right side, and then I come back and I take, identify the pubic symphysis, go 1.5 centimeter leads to the pubic symphysis, and then you can see in this picture. So 1.5 centimeter lead to the pubic symphysis, the Cooper's ligament. You don't see the ligament leads the periosteum thing only, basically, and then you take the same stitch which we are holding in the vaginal mucosa with the needle. So I take stitch with that on 2 on the basically on the left side, 2 on the right side, and in the end, my assistant basically I just tie the stitches. So the stitch should not be too tight. but you can see my assistant can see the vaginal mucosa being lifted up. So in other words, basically the proximal urethra, which normally is intra-abdominal, was made basically when came out of the pelvis, perineum, out of the abdominal cavity because of the childbirth trauma. So I have brought that back into the peritoneal cavity. So now the rate in abdominal pressure is communicated to the urethra also, and that's why basically works basically. So it's basically putting two non-absorbable stitches on either side in the paravaginal tissue over the vagina and tying to the exhalatory Cooper's ligament as shown in this picture. And so the results are brilliant. I mean, that got almost, we did a study, comparative study between basically this Burch Colpus suspension versus POT, and we found almost 90 to 95% success rate. Next, please. Okay. Only thing, it's a major operation. You have to give the patient for about 3 to 5 days. And initially, I used to keep the catheter for 5 days, but I mean, you can keep even up to 3 days, 72 hours at least, and give some antibiotic to the patient and discharge the patient of this. Only thing that bladder injury rate is less than. I mean, in my case, I mean, only once I put the stitch and I did a called cystoscopy, so we remove that stitch immediately. And rarely there can be risk of urinary kinky, urinary tract infection and denoted instability. And luckily, I had 2 or 3 patients. I done about 98 odd births by now. Only 2 patients I had problem of urinary retention, and they also. So 1 patient I had to keep catheter for almost 14 days, and gave her antibiotic, anti-inflammatory, and ultimately we were able to remove the catheter. So none of the patient required basically removal of the stitches. But once I got a phone call from one doctor, surgeon, and that patient became completely anuric. So that was probably he put the stitch too tight. So that is the problem. And then I said, what can we do now? So sometimes you have to actually go back and remove the stitches if the patient is totally unable to pass urine. And that means you have made it too tight and completely close the urethra. So then you have to remove it. But luckily in my study, only 2 patients had problem, and they also were after giving antibiotic and anti-inflammatory. So when you're tying the knot, basically don't make it too tight. It should just basically should be just lifted up and up to the goes up to the pubic symphysis, you can say, or later to that, but not too tight. So these are the complications, and sometimes there can be risk of enterosis because we are lifted it entirely, and dyspareunia rate is very low, and some patients may have detriment instability de novo. But I mean, most of the patients, like I did in one patient that was the mother of one doctor from AFNC Pune, and she had mixed incontinence actually. So after that, her basically SUI became all right, but she had overactive bladder syndrome, and then so she was not that satisfied. So these are the patients, so you should give them clearly that this SUI surgery will not treat her overactive bladder syndrome or overactive bronchitis. For that, she still has to take anticholinergic drugs or mirabagrone, etc. So that is important. Next, please. So, but having said that, Burch Colpus gave excellent results, and I keep on doing it. I never stop doing it. And now with the question mark on message, it has still had a scope. And you can do it by laparoscopic route if you are happy with that. Otherwise, by being next slide, please. Okay. So these are the basically, advantages of transabdominal versus laparoscopy. I mean, both operations are equally good. We had done a study. Dr. Kripani used to do laparoscopy. I used to do open method, and we are trying to compare the results. Results were almost equally good, but slightly better with the open, because with the open we always take 2 or 3 stitches on either side. With laparoscopy, some people take only 1 stitch, so then results will not be. So if you are doing laparoscopy, then take 2 stitches on either side, so that is equal. But definitely, I mean, laparoscopy takes 3 to 4 hours, while open Burch can take. I do it in 30 to 35 40 minutes, and otherwise some people and and I tend to combine with open abdominal hysterectomy can be combined with Burch. In fact, just before this COVID wave came, I had done an operation, just about 3 weeks back, just before COVID wave. And we did abdominal hysterectomy, and then I did my Dr. Rajesh Kumari with me. I made her do actually laparoscopy, this open Burch Colpus suspension. So in the same sitting, so first you do abdominal hysterectomy, and then you come out in the intrapubic area and then do the Burch later on. So don't do Burch first and then do hysterectomy. Do hysterectomy first and then do Burch. Similarly, do vaginal hysterectomy first and then do TOT or TVT. That's what I do. So that whatever angle has to change, let it change by hysterectomy, and then you restrict yourself to the this surgery. Next, please. So Burch Colpus remains one of the gold standard treatment. Next slide, please. And you can do either abdominal as well as laparoscopic route. Next slide, please. Okay. So, and do not offer laparoscopy as a routine procedure for the treatment of stress incontinence in women. Only an experienced laparoscopist should perform the procedure. Next, please. So that is important. I mean, because the and other operations, just to basically there have been various procedures. Now there has been a question mark about the message. So even including PVT, TOT were not available like in UK, and some patients had the so though most of the problem of the message were with the large message people used to use along with the surgery done for prolapse surgery, like complete message, not with the TVT or TOT, but like some patient had with the TVT or TOT also. So there may be a problem. So we have to so we did a thesis. Dr. Mansi, my PG now, our senior SR now. So we did rectus fascia sling. You can use fascia lata also, but as a gynecologist, I mean, we are more happy to do rectus fascia because we are doing it ourselves. Like I keep on doing Purandes Raikopexy. So I was experienced with that. So we can do rectus fascia sling. And now there's a question mark, and there's a real chance that tapes may no longer be available, even in India, if the DCGI doesn't give us permission. So that we have at least something to use, we can use rectus fascia sling. Next, please. Others, I mean, Ox, Dura, Ports and Derby, just to complete the list. So for sling operation, basically traditionally reserved for, incontinence and can be considered for surgical treatment of primary SUI, or, they have short-term complications can be there like bladder infection or active bladder symptoms, wound hematoma, and or voiding dysfunction, but usually that's good operation. Next, please. I'll be just showing you some slides of that. Yeah, okay. So this is the thesis which we completed. We did on, we have done now on about 20 patients, and the paper had already been published in European Journal of Obstetrics and Gynae. That is a head-on collision study comparison and RCT between basically rectus fascia sling surgery versus TOT. And definitely the TOT was faster, like, it could be done in, I tend to do in 12 to 15 minutes only TOT. And this took about half an hour or so. But this also we could reduce the time limit because we had two teams working on. So Dr. Rajesh would work from the vaginal root. I mean, she would do anterior, 3 to 4 centimeters on the anterior vaginal wall, separate the basically urethra from the vaginal mucosa. And you have to make dissection just like you do for TVT or TOT. So separate the, give a vertical incision on the vaginal mucosa, separate the urethra from the vaginal mucosa almost up to the ischiopubic rami on either side. And then from above, I gave a transverse incision. Then I cut a didn't open the peritoneum. I made a, you can see the rectus fascia. So I cut a 8 into 2 centimeter rectus fascia sling, complete. I cut it, you can see on the right hand side. And then we put it in the basically solution containing saline, gentamicin, and some hydrocortisone. And then Mansi used to put 2 stitches on either side of that, non-adherent stitches on either side. And from above, then just like you work in the in the K of Hitches, I worked, and then I could, and from below we had put the Foley's catheter. Patient in the lithotic position. So same way, Foley's catheter in inflated bulb I can make out, and then I with my left hand I can make out the bladder neck, and urethra. Okay, so same way, just like you do birth purpose suspension. So inflated bulb with the bladder neck, catheter is urethra, and then on either side of that I used a basically some people are using TVT these things also, but I use simple clamp basically from above, and from below my assistant has already basically done a good dissection. That means he has separated the urethra from the vaginal mucosa on either side. So from above now, later to the bladder neck, I mean, this is the bladder neck, this is the bladder, this is the urethra. So later to that, I'm going from above, and the clamp can be seen by my assistant from below, and then she makes a tiny nick on it, just on the tip of this, and then so my the clamp can be seen from vaginal end now. And then my assistant basically feeds the thread of this tape what we have cut rectus fascia sling on left side, and then I repeat the same thing on the right side also. So in other words, now I have put, you can see in the picture on the below. So this is the rectus fascia sling from below, you can see, and this has been tied. I have lifted by me by putting through this, and now so the stitches are being put anterior to the rectus on the abdominal wall. In other words, basically the rectus fascia 8 into 2 centimeters sling is in the mid urethra level, and then anteriorly and anti-abdominal wall. And I'm putting a, like you can say, artery forceps underneath, so that's not too tight. And same way at the abdominal end also, I'm putting an artery forceps underneath, so that's not too tight. So I tie the stitches basically anterior to the rectus seat. So in other words, this basically is a mid-urethral sling. In the first case, actually we put in the bladder neck, but that patient had actually nearly 2 to 3 weeks couldn't pass urine. So then we started in the mid-urethra. So it's just like a TVT, basically TVT of tape. Like instead of polypropylene mesh, I'm using the patient own rectus fascia, and you can see this like 18 tube is on this side, and then it's tied to the anti-abdominal wall, basically to the rectus sheath. And then because we have cut the rectus sheath from above, so you have to make a good dissection. And then initially 1 or 2 patients had hematomas, so that's why after that we started leaving a drain routinely. So all these patients, and catheter also we initially we put for 5 days, but now I'm putting for 72 hours. So you need to leave the police catheter for 72 hours. You need to leave the drain for 48 to 72 hours in the abdominal wall, and then don't make it too tight. So after 72 hours, you can move the catheter. In 2 to 3 patients, we had to keep the catheter for 1 patient 1 week, 1 patient 2 weeks. We had to give her antibiotic and inflammatory agents, and ultimately we were able to. In 1 patient, I was even thinking of cutting the tape, but luckily after 2 to 3 weeks time, then she was able to pass urine. Okay, so you have to have patience. So initial hiccups are there, but it's the patient's own rectus fascia, which is like TOT cost 30 to 35,000 rupees. Rectus fascia is her own fascia, and it can never cause mass erosion. It's so her own, and patient body will know like it's her own fascia. So this is what we have basically developed this now, done more than 20 cases actually already. Because of COVID, we couldn't do more cases, and even but last year also, like in between the 2 COVID waves, we could do some cases, and the results are excellent. Patient own fascia. Only thing it takes about like in my case, it took only 35 to 45 minutes, but my TOT time is only 10 to 12 minutes. And so this is, only thing some patients, you give them antibiotic and inflammatory, just like for births, leave the catheter for at least 72 hours. Some people leave for 5 days also, and then remove the catheter. If she is able to pass urine, then she goes home. Otherwise, like, about 5 to 10% patient may require catheter, like 1 patient. Then I left the police catheter, sent the patient home, and then called the patient after a week to 10 days. And then you remove the catheter and see whether she is able to pass urine or not. Sometimes in 1 or 2 patients, I had to keep the catheter for 2 to 3 weeks also. Next, please. But results are excellent. Almost all patients were cured of the SUI. None of the patients had SUI. My paper already published in this thing. So this is almost similar basis, though it is the old slide. Next, so this is how basically the rectus fascia will be tied. Next, please. Okay. So this is the paper already published in European Journal of Gynaecological, autologous rectus fascia sling surgery, which we have done, and we got very good results. Success rate was almost 100% in this case, and mean operating time was 55 minutes. Next, please. And most common complications are urinary retention. So this is so these are the other, like you can use synthetic lithoPV sling, synthetic transoperator sling, synthetic single incision sling. Next, please. Next slide. Yeah. So this is the standard TVT. All of you know, Dr. Amita Jain does a lot of these cases. So this is a very simple operation, and you make basically in this case you don't do anything abdominally. You put the vaginal lithotomy position, make a vertical incision about 3 centimeters on the antevaginal wall, separate the vaginal mucosa from the urethra, and on either side of pubic rami, and then you just take it and take it into anti-abdominal wall, and you need to put a Colles catheter or this special instrument into the bladder and take it to one side, and then you take it one on either side and take it to the anti-abdominal wall. But you put both tapes on either side basically, and then you do a cystoscopy, because there's 6 to 8% risk of bladder perforation. But even if there is so on the cystoscopy you will see the sling going through the bladder. So in that case, it's not a big deal. You don't have to do laparoscopy or do anything. Just withdraw on that side and go later to that. So I mean, perforating the bladder with this is not a big complication. You don't have to do laparoscopy. You don't have to call the urologist. You can just do it lately. So you don't need to close the bladder with this. So but still 6 to 8% bladder injury rate to me is unacceptable. So that's why I shifted to basically TOT. But this is what I mean. You can do downside up, upside down. The Johnson & Johnson I do from basically below upwards, and this patient can be sent home same day or the next day. I tend to leave the catheter for 24 hours, and then next day morning I remove the catheter. If she is able to pass, give just one sort of antibiotic to the patient, and if she is able to, I remove the catheter next morning. If she is able to pass, I send her home, and only 5 to 10% patient may require catheter little longer. Next, please. And it is like Aparna Hegde says that in case of, and I also my experience in case of if there is intrinsic sphincter deficiency, then this TVT, standard TVT is a better this thing. Almost 89 to 90% cure rate, more than 7 years. Statistically, results have come out brilliant. Next, please. Only problem is that, this, so almost 2 to 4% bladder perforation rate is there. And we know that the instability 10 to 12% is there. Rarely, you can injure the, bowel perforation, major vessel injury is very rare with it. And next, please. Some patient may have described. Okay, and this is the TOT which I'm using now, because this 4 to 6% bladder injury rate to me is unacceptable. So then, this TOT is available. In this case, you can say that we make a 3 to 4 centimeter. In this case, deliberately the incision has been made 4 centimeter for demonstration purposes. Otherwise, normally I do 2 to 3 centimeter only. But for demonstration purposes, I made a bigger incision in this case. So separate the basically vaginal mucosa from the urethra, and then on the right side I put this tape. Basically, you can see on the upper and this is the it's a carrier. So it's basically more oblique, and they should you can know which is the right and which is the left one. So you put it this helical passer, and the risk of damage to obturator nerve and vessel is there, but the risk of injuring the bladder and urethra is very almost negligible. And you can do outside in or inside out. I tend to do inside out more commonly. The Johnson and Johnson one. Next please, called Obtape. Next please. Yeah, so you can see this is how it goes, basically through the obturator foramen. And if you see the obturator foramen, we divide it into 4. So if we stay medial to the pubic ramus, in the middle compartment, upper one, you stay, and as you see in the right hand side, that how the tape ultimately will sit. So there is no virtually very negligible chance of injuring the urethra or bladder with this. But there is maybe slight risk of injuring the obturator vessel if you go later to that. So the security, you stay close in the middle half where the vessels are not there. Next please. And excellent results. I have done almost more than 100 cases now. I tend to do inside out, but people are doing outside in also. Results are equally good. And only problem is slightly groin pain, and with the because it is coming out, the needle is coming out to the groin. So there, some patients may have groin pain, but usually if you use the abrevio of the TOT abrevio, in which the stitches basically the message in the central half and little half of the suture, which ultimately removed. So then the chance of groin pain will reduce. Similarly, injury to obturator nerve and vessel, luckily I never had it. Mesh exposure. I have done nearly 102 patients now, and in 2 patients I had partial mesh erosion. And one was actually wife of Deputy Commissioner of Police of Delhi, and second was a bank manager, of State Bank of India. And then I like both of those patients, actually the patients were a little bit older, and both of them had hysterectomy in the past, and their vaginal mucosa was thinned out. So now I can make out. So ever since I need these patients of if they are menopausal patient, if they had hysterectomy in the past, then I tend to give them topical estrogen therapy. And in that patient also, ultimately what I did, there was about half centimeter mesh erosion. So I just removed that extra mesh, and then a little bit more than that. You don't try to remove the whole mesh. And then I just closed the vaginal mucosa on top of that. And after that, patient became all right. And I thought that she will become incontinent now, but no, in fact, before COVID, he invited me for dinner, though I couldn't go. And that means, and he said she's fine. So she has remained continent. Similarly, that other State Bank of India manager, lady also, she also had actually hysterectomy in the past. And otherwise, all other patients are fine, and I can find any mechanism. But unfortunately, there has been some. How much time I got? I'm about to finish. Next, please. So 84% success rate is there. Next slide, please. Yeah. So the same thing. So others, you can use the mini slings also, but I tend to use. My advice to all of you will be there that you restrict to 1 or 2 operations. Like I do only 3 operations. I do burst corpus suspension open. I do TOT now. I used to do TVT. I do TOT inside out, only 1. And now average of the Saverson, and I now switched on to the rectus fascia sling surgery also. So only 3 operations I'm doing, and I'm good in that, rather than trying to do 10 operations. So I'll advise to you whatever suits you. And this TOT is very, very simple operation, 10 to 12 minutes, excellent results in my experience. But only problem is that because of the mesh erosion scare, and it may not become available, may not be available in India also in near future, because not available in UK. So then you have to find alternative, and I already found alternative in the form of rectus fascia, which is a bigger operation, definitely has more complication, has more bladder retention rate as compared to standard TOT. But you don't have any choice if it's not available. Next, please. I still feel TOT has good results. In fact, one of my friend consultant in UK, he did a tape on a lady. That girl was basically sports person, and she used to leak urine. Unmarried girl, she used to leak urine, and then he did a tape on that, on her TOT tape. And after that, she won a, in the European Championships, she won a, a gold medal probably, or silver medal. But that lady never came on TV or any newspaper. So that means the positive, basically, we never got positive, feedback from the patient. They never tell, but negative feedback, patient came on TV, they came on newspaper, media, and then, so that's why this mesh erosion. So England government announced pause on the use of mesh for SU and prolapse surgery in next, please. I'm about to finish in 1 or 2 minutes. Okay. So that's why, so that's why we have to find alternatives. So luckily, I never stopped doing burst corpus suspension. I'm still doing burst corpus suspension. I've learned now that facial sling surgery, which all of you can also learn. I mean, you can read our paper, and I'm happy to. I published in the Indian Yogi Journal also. Review article on it. You can see that also. And any of you want, I can send the paper, copy of my paper to you. And as far as this Kelly's repair, etc., you can do it, but the unfortunate success rate of Kelly is very, very less. So not really recommended. But as a part of the patient who was 3rd-degree prolapse and mild to moderate, you can combine with that. But usually I tend to combine vaginal hysterectomy with the TOT, sir. Because I get good results. So I do vaginal hysterectomy first, then I put the TOT, and results are excellent. So you can combine in one patient. We combine with the rectus facial sling also. Next, please.
Sir, please, we are running out of time.
Yeah, so I finished it. Thank you very much.
Thank you, sir, for an excellent, nice, elaborative.
So any questions here? So I want to highlight. So you learn 1 or 2 procedures and keep on doing them. And rectus facial sling will have a role in future because of the non-availability of the tension-free tapes and all. But if they remain available, tension TVT and TOT are good alternatives. Very simple techniques to learn, 10 to 15 minutes, and excellent results.
Yes, yes.
But
in the question box, I am not able to see any questions. But one of our senior member, Dr. Trivedi, is with us, and he has a question. Only we will take only one question.
Okay.
We are running out of time. So, our senior member, Dr. C.S. Trivedi, he is with us, and he has a query of. You can ask.
Sir, how can we prevent the problem which we are facing? That is one. And second thing is there any other technique by which surgery not requires to get the result?
Sorry, sir, I couldn't understand the question. What?
The question is the problem which we are facing. Can we do something by which it can be prevented physiologically? And second thing is, if surgery is not done, instead of that, can we do something else so that surgery is prevented?
Okay. So, yeah, sir, actually for mild to moderate incontinence, I told you that we can avoid doing surgery. We can ask them to reduce weight. We can ask them to do lifestyle changes, pelvic floor exercises. We can ask them to basically do bladder training in the form of time passage of urine 2 hourly in first week, 2 hours 50 minutes next week, like that they can go to 3 hourly. And right. Then duloxetine is one drug, sir, 20 milligram a day. Right. For 2 months you can give, and you can go up to 20 milligram twice a day. Okay. So with that, almost 60 to 70% patient will be benefited.
Okay. Thank you, sir. We are running out of time. That was an excellent session.
Thank you, sir.
Thank you, Amita madam, Jagruti madam, and over to Kajal and Purvi.
Yes. So thank you, Dr. J.B. Sharma, sir. Now moving towards the next session, the most awaited topic for the day, that is a cystoscopy by gynecologist, will be taken by Dr. Amita Jain. And to chair the session, I would like to invite Dr. Jagruti Desai, madam. She is the president of Surat OBGYN Society at present. She is a laparoscopist, obstetrician, and gynecologist, private practitioner at Udna Hospital Private Limited, Surat, and a visiting consultant at Nirmal Hospital, Surat.
Our next chairperson is Dr. Sandhya Chhasatiya. She is a senior consultant obstetric and gynecologist at Sandhya Hospital, Surat. And now our Dr. Jagruti Desai will introduce our next speaker, Dr. Amita Jain. Over to you, ma'am.
Hello, welcome Dr. Amita Jain. She is the founder member of FEPPA, board member of GIBS, a senior consultant urogynecologist, Vedanta, the Medicity Gurugram. She'll be guiding us and telling us how to do, when to do, and how to manage all the gynec patients who are complaining of like hematuria, fistula, and whenever we feel in post-operative cases, if we suspect any bladder injury, ureteric injury, so how to go on in all these cases with a cystoscopy. Welcome, Dr. Amita Jain.
Thank you so much for this nice introduction, ma'am. I would like to share my screen. So I hope you are able to see my screen.
Yes, ma'am.
Yes.
So the thing is, yes, thank you very much, ma'am, for giving me this topic because it's very close to my heart. I personally think that each and every gynecologist, whosoever is doing advanced surgeries, whether it's gynae-oncology, urogynecology, anything, must know cystoscopy. So as you know, name suggests that it's an endoscopic procedure which is done to examine the inner side of the bladder as well as urethra. And as with other endoscopic procedures, it can be done either with flexible or rigid endoscope. And it depends that whether you want to go for a local or general anesthetic, because there are certain advantages and disadvantages of both types of approach. Like for the rigid cystoscope, because it's having a wider channel, so there would be a better irrigation, better visualization of the field, as well as because of the wider working channel, you can introduce more instruments, and that's why you can do many procedures along with this thing, which is not with flexible one, because flexible one, all the channels, whether it's opticals or even the working channel or the irrigation, everything is inside one tube, and that's why there is limitation of irrigation and visualization as well as doing some kind of procedure. So usually flexible one is used in for office procedures like in OPD, and you can do it in under local anesthesia, while the rigid one can be used even for the operative one. So I'm just showing some instruments. I know you, most of you must be well versed with hysteroscope, and I'm telling you it's quite similar to the hysteroscope. The lens we commonly use is 0, 12, 30, 70, and 120 degree. We know what is the degree. It's the deflection of the lens along the long axis. So as we know that for the just examination of urethra, once you need a direct visualization, then only these 0 degree or 12 degree is required. Otherwise, mostly for a cystoscopy, 30 degree lens is used, and it gives a good front view as well as lateral view. But once you want to examine the lateral walls or the anterior wall of the bladder, then probably 70 degree lens is required. For the 120 degree, that is retrograde vision, actually it is not required for cystoscopy. So this is the telescope. This one is outer sheath, similarly like of hysteroscope. Obturator would be there. There is a bridge, which actually bridge, you know that it holds the telescope, and especially for the cystoscopy, once you want to remove the telescope, either want to change it or wants to evacuate the bladder. So you don't need to take out the outer sheath. You just can do it by removing the telescope. So that's the beauty of bridge, and also it's have sometimes angled arm to introduce instruments. There is a special Albaram arm which is found in few bridges. It is actually on the tip, there will be a deflection mechanism, and by which you can actually manipulate the instrument inside. Other things are pretty similar. About the irrigation system, we all know that normal saline is best because it irritates the mucosa least. But once you are using some electrocautery, you have to use the non-conductive solution like glycine and all. So here you can see in this video how the instruments is assembled. It's similarly with the hysteroscope, bridge with outer sheath. Then you have to introduce the telescope, almost similar. You can see that the bridge is having 2 channels for the instruments, and you have to lock everything. You have to use the light channel, the camera later on. Everything is almost same of hysteroscopy. Nothing is different. Then you have to do a white balance, and here you have to do a irrigation beforehand just to avoid bubbles, to have a better vision, and you must introduce the cystoscope while the irrigation is on. Otherwise, you won't be able to see the urethra. That's the thing. So, so next question would be that what is the difference between two? So I don't see this slide. See these 2 slides on the right side, and tell me which is the cystoscope and which is the hysteroscope. So I think it's very difficult to differentiate. The only thing, in this slide, you can see there are some fenestration at the end, which is hysteroscope, because it's required for better irrigation. The difference is that you can know the difference in the organ. The bladder is a distensible organ. It is balloon-like. So you actually, you don't need a high pressure to distend. You can just apply a normal saline with a, you have to keep it at a height of 60 to 80 centimeter of water that is above the pubic symphysis of the patient. And then just you have to allow a spontaneous flow, and this will automatically fill the bladder. So, and you have to distend with the, comfortably filled bladder. Otherwise, if there would be over distension, you won't be visualize the ureters and many things. And even during the biopsy, it would be difficult because you won't be able to take a good punch because of the over distension. And also there are chances of rupture of the bladder. So these are the things which are different from the hysteroscopy and cystoscopy. So, that's the thing. Otherwise, there is no difference. And actually, what urologists do, that they sometimes use their cystoscope for hysteroscopy, and gynecologists do use the hysteroscope for cystoscopy. So these are the the principle is almost same of both the devices. So I am showing you a short video of performing the procedure. You can see, similarly, you have to apply the xylocaine jelly. You must know that there is always a nozzle over the xylocaine jelly tube. So just apply that jelly beforehand into the urethra directly, especially if you are doing the cystoscopy under local anesthesia, because urethra is quite a sensitive organ. So you have to do that beforehand. Then, because the urethra is just 4 centimeter long, so you just have to apply the xylocaine cream at the initial part of the cystoscope, and then you have to apart the labia and see the urethral orifice, and under direct vision you can introduce the cystoscope. And you can see the whole of the urethra length you have to examine, because if it is pink, it's okay. But if it is white, that's mean it's the atrophic changes. Or if it is too pink or red, it's mean it's urethritis. If inner vision is not good, then you can evacuate the bed, especially if the urine is concentrated, then you have to evacuate. I have shown it how. Then just look at the thing that once you enter, then you have to actually lift the cystoscope above so that you can see the below ureteric orifices. So you just have to identify. I am showing this is the right one, and you can see the right ureteric orifice beautifully, and urine coming out of the orifice. And then you have to follow the interureteric ridge to see the left side of the ureter. And here you can see the peristaltic movement very nicely. It looks like your orifice is winking on you. So in this way, you can see the trigone, then on the base, then I'm going to the posterior wall. There is no methodical way that how to examine, but actually you have to examine each and every one. So reach up to the dome, then again come back to the ureteric orifice so that you can see that the whole of the lateral wall. You can see laterally that I am showing that how I am just keeping the camera stable, and I am moving my light cable on the opposite side once I want to see the lateral wall. So it's the way you can change the direction. This is the dome, because the bubble is indicative of dome, and you can press to see the anterior abdominal wall. And then you can again come back to the left ureter, and again you can follow the same thing to see the left lateral wall of the bladder. In this way, you can complete the whole view. So this is these are some tips to do the cystoscopy. For the flexible one, I have already explained that because you are having all the channels within one tube. You can see here in this diagram, that's why there are some limitations. The beauty is that you don't need to use different lenses here, because usually at the tip there is a deflection mechanism, and you can regulate it by a lever on the eyepiece, and you can actually sometimes deflect up to 290 degrees. So you can actually turn off the tip towards just opposite side, and then you can visualize. So the tip here is that once you have turn it to a certain degree, then don't try to you have to do one thing in one time. That if you are looking for you are turning the scope, then don't turn the tip, otherwise there are chances of damage to the lens. So these are the difference. You can see how the setup can be maintained for the flexible one. Now, there is European Association of Urology has given this a nice diagram to just make the ease of, for recording whatever findings you have. So you can see that that's the actually the anterior wall. This is the posterior wall. This is the base. This is the lateral walls, and these are the both ureters. So you can use your own way of telling what are the findings in the diagram. Now, what are the risks? Yes, there are certain risks, though it's very, very safe procedure, but yes, there is a very common risk of some little burning or bleeding after passing urine. It can occur. You just have to explain these things to the patient before taking consent of the same. Sometimes there is an occasional risk of infection. If you have not used a pre-operative antibiotic, usually we use one shot of injectable antibiotic, or if you have not maintained the sterility, and rarely there would be need of temporary insertion of it. Look, it's a procedure, and sometimes, because this is a very sensitive organ, if pain is there, and because of the pain, you must know that females are pelvic floor voiders. So because of pain, if there would be spasm, then probably the chances that patient temporarily won't be able to pass urine, then probably you have to use catheter for a while, especially in presence of bleeding. A small clot can cause obstruction at the bladder neck. So we usually recommend catheter for a while till the bleeding is stopped, because otherwise patient may go into retention, and you have to be very vigilant about the bladder. It's not like uterus. So you have to be, you have to be very careful. Sometimes even if you are using force, you can actually cause a rupture of the bladder and also the bleeding at the bladder. Usually for uterus, we never use any kind of electrocautery because of the tamponade of the muscles of the uterus. Bleeding usually stop, but not with in case of bladder. Once the bladder is distended under vision, probably because of the blanching, there won't be bleeding. But once the bladder is evacuated, the bleeding will restart. So you have to be very careful for maintaining hemostasis, especially if you are doing a procedure like biopsy. Now, the indication. Before going for indication, the only contraindication is acute urinary tract infection. Otherwise, if a patient is coming to you with recurrent UTI, but there is no active UTI at present, or there are urgency frequency, you have to do sometimes cystoscopy to rule out interstitial cystitis, which could be a differential diagnosis. Even, some kind of diagnosis like tuberculosis or something, you can find out just by doing the biopsy. You have to do to identify intraoperative injuries. I will show you some videos later on, like after putting mesh, you have to see any mesh or suture is inside the cavity, or fistula, ectopic ureter, and especially in case of hematuria. So microscopic hematuria you can see, but for the macroscopic one, I will suggest that please refer to the patient to a urologist, unless until you are well versed with the things. And staging of gynecological cancer, because if there would be bladder invasion, probably the staging will change. Therapeutic purpose, usually for gynecologists, these are limited, because if you are not very well versed with the suprapubic catheterization, you can do it under direct vision or under cystoscopic vision. Other procedures which can be done are intradetrusor botulinum toxin A injection, as told for bladder pain syndrome, or more commonly for overactive bladder. Injection of bladder neck bulking agent. I hope Dr. J.B. Sharma must have mentioned this is a procedure for treatment of stress urinary incontinence caused by intrinsic sphincter deficiency, and bladder neck incision is a procedure which is done for bladder neck obstruction. So these are the pictures. Just quickly, I'm showing you that these are the pictures of interstitial cystitis. Typically, patient will present with decreased capacity on bladder diary. Patient is not able to retain urgency, frequency, everything is there, and all the reports, routine, culture, everything is normal. Then you will land up in doing cystoscopy. These glomerations are not pathognomic. Any small capacity bladder will have these kinds of picture on distancing. But these ulcers could be pathognomic, which are called Hunner's lesion. It's sometimes blanching would be in middle, scar would be there, and radiating vessels you will see. You can leave these lesions because sometimes interstitial cystitis will look like absolutely normal, but for the angry looking ones, if there are some kind of tears or atypical scars, you might need to take a biopsy. As I can show you here, that as Dr. Khullar also mentioned, that sometimes looks absolutely normal, but on distension you will see these kinds of hemorrhages, spectacle hemorrhages, these kinds of bleeding will start, these kinds of atypical scars will start, and then gradually waterfall sign, it will start bleeding more once you are distending, and you can see later on that even there would be some kind of mucosal tears. So these kinds of the things where for the treatment part, if you are well versed with the kind of resectoscope, use of resectoscope, you have to burn these lesions. As you can see here also, these are the typical scars with ulcerative lesion in the middle, and you can see that on distension how the glomerations are developing. These are the typical tortuous vessels you can see on interstitial cystitis, and on further distension, these are the mucosal, the white areas are the mucosal tears. So it's showing the advanced stage of the disease. So these are the findings you can see. And if you are looking something abnormal, this is a very abnormal area, then don't leave these areas. You just can take a cold cup biopsy. Just have to be very careful. Bladder should be comfortably filled. It's not over distended. And then you can take kind of, it's a kind of punch biopsy. You just have to take a part of normal mucosa along with the abnormal area. And sorry. And as I told you that after that, the hemostasis, which is very, very important. So here you can see that I am using the Bugby, which is a kind of monopolar diathermy, which is used to burn those bleeding sites. It's very, very important, and re-examine the patient after evacuating the bladder to see whether complete hemostasis is achieved or not. So now I'm playing this video. Anybody from the faculty can tell me what is it? Anybody? So this patient presented with, cyclical dysuria, hematuria, pain was cyclical in the bladder, the painful micturition was there, and you can see both sides of ureter, and the ureteric ridge is lifted with this kind of lesion. So anybody?
Endometriosis.
Only gynecologists can answer this question. Yes.
Endometriosis.
So these are the things you can actually take the biopsy. You can manage better than a sister, I think, urologist. So now this is the thing. Can anybody tell what is it? So basically, it's a swelling at the urethra, and once on pressing, you can see the pus is coming from the urethral opening. So this is the cystoscopic picture. So you can see that sometimes one gland of the urethra can open directly into the urethral lumen. It is called urethral diverticulum, or once it is infected. So these kinds of picture you can see, and here to see through cystoscope, that opening is very, very difficult because to distant urethra is very difficult. But yes, you must be vigilant about these things, and you must use 0-degree lens for this thing. Now, voiding dysfunction, you must be getting many patients that they are not able to void. To tell you rightly, urethral stenosis or urethral narrowing is very, very uncommon in women, because women have a very wide urethra, and unless until there is a trauma or some kind of major disease, the urethral stenosis doesn't occur. Then what occurs? There are some kind of voiding dysfunctions, like dysfunctional voiding. Patients are not able to relax their urethra, or there could be even hypertrophy or their bladder neck. So these are the conditions which you have, if you are working as urogynecologist, you must know. And also, if you are going to examine these patients without anesthesia, we will find patient will squeeze because of the fear factor, and you will find that urethra is stenosis, and you will wrongly diagnose, and probably most of the even the urologists land up in doing urethral dilatation, and this will cause damage to the urethral mucosa, and these patients will later on land up into urethral stenosis. So I already showed you how to do a urethroscopy. You can use a 0-degree lens, and then you can see under anesthesia the urethral lumen is absolutely normal. You are able to even introduce a 22 French cystoscope inside. And then sometimes on chronic obstruction, these kinds of picture you can see. The hypertrophy of detrusor muscle, because it's a crisscross muscles, it will look like this. These kinds of it's called grade 4 trabeculation, and you can even see the diverticulum. You can see a big diverticulum, and actually you have to see inside the diverticulum to rule out any malignancy or any abnormality. So these kinds of pictures you can have. These are the actually diagrams of the micturating cystourethrogram where bladder neck is not open. So this is for the diagnosis of hypertrophy of bladder neck, which is called primary bladder neck obstruction. And once you are doing a urogynecology, you must know how to use a Collins knife to give an incision over the ventral end. Never use the dorsal end to cut, because it can produce a kind of fistula. So you can just use this kind of incision to open the bladder neck. Sorry. So what are the guidelines statements? So American Urological Society have told that for any kind of prolapse procedure, whether you are doing sacrocolpopexy, abdominal anything, you should do a universal cystoscopy. Even AUA position statement, after use of any vaginal mesh. That doesn't mean that only after TVT. Even after TOT, even NICE is saying that you should do a urethroskopy, because I will show you some videos, because whatever injury you should detect at the time of surgery. It will be delayed, it will cause dire consequences. As you can see here, you can see the trocar inside on the left side. So it's after the insertion of the trocar, and you can see after removal, this big hole is there. But you can reintroduce the trocar, and you can keep the patient on catheter for a while. That will be easy solution rather than picking it later on. And you can see on the even opposite side, there is a trocar entry. So on both the sides. Sorry. So if you are not able to detect it and you have placed the mesh, probably these kinds of things can be happen. This was a very interesting patient, because I found on third day that after removal of the catheter, patient was having quite a lot of fluid excretion from the suprapubic wounds. And once we analyzed that fluid, that was urine. So it was very surprised. I was very surprised. I did the TVT. So we did a repeat cystoscopy. We missed it because we actually didn't use the 70-degree lens. And after that, we were able to find out this thing, and we just removed it because we just detected it on third post-operative day. So that's why we were able to remove that sling after opening the vaginal incision, and we just kept this patient. We reintroduced the sling, and then we just kept that patient for 2-3 days catheter, and the problem was completely resolved. Just have a look of this. Everything was normal into the bladder. But why I was stressing that even the urethroscopy is important, that now you can see there is mesh into the urethra. Or this was very interesting patient, because this patient had an extensive surgery and was kept on leger stent on both the sides to avoid ureteric injury, and was having a copious discharge from the drainage. And you can find that abdominal drain which was put after the surgery was actually inside the bladder. So these are the small things you can do. You don't need to wait for urologists for these kinds of indications. Sorry. So if suppose you're not able to detect it at the time of surgery, what will happen? So sometimes if you're finding that these kinds of sling inside, you won't be able to actually take it out from the vaginal end because of the fibrosis. So now you have to actually cut it inside the bladder. So here we are using the hysteroscopic scissors actually to cut both the ends, and then we have removed it by using a forceps. Here you can see This is actually a kind of a stone which is formed over the thing, and it was so fibrous that we have to use a laser for cutting these kinds of stones. So it's very difficult if once the stone is formed. So never neglect the symptoms. If you have played a sling and patient is having some kind of symptoms of dysuria or pus cells or recurrent UTI. Even this is a video which is after 10 years, patient actually presented with this kind of a stone, and it was difficult to diagnose whether it is a stone or not. So I tried to go beyond this stone, and once I found that yes, I can go, that's mean it is a stone over the sling. So sling got eroded. It was not at the time of surgery. So you can see that that's the thing. It is a stone over the sling. It on the eroded part. Sorry. So quickly, preoperative stenting can be done. There are two school of thought. Somebody says that after introducing the stent, you are actually making that ureter more stiff and there are more chances of injuries. But latest paper has said that whether you are stenting or not, there are not much difference, and it's better for higher grade of surgeries to do the stenting. At least you will be able to identify the injury at the time of surgery. So here you can see that this was a kind of difficult stenting because of the ovarian mass, huge ovarian mass, and bladder was stretched over the mass. So you might require a help of your urologist for these kind of stenting. Otherwise, stenting can be done easily. You don't need to reach up to the kidney. You just have to stent the initial part of the ureters. I think time is less, so I will just show quickly you some kinds of fissulas and how to differentiate between the trigonal and supratrigonal fistula. Here you can see this is a fistula just above the right ureter, and here you can see on vaginoscopy you can actually do the stenting from the vaginal side, and here you can see again supratrigonal, which is above the trigone. The fistula is there, and you have to see whether it is quite near to the ureter, whether any kind of ureteric reimplantation is required. Otherwise, you can do the surgery vaginally. Just want to show this interesting case. It is a video of trigonal fistula, because trigone at interureteric ridge. This is a very interesting case because this patient presented with cyclical hematuria, and as you can see here, that this is the right ureter, left ureter, and this is the fistula side. And what is more important was that on vaginoscopy in this patient, I was not able to find anything because it was a utrovesical fistula. So these are the things you can actually sorry. So I think botulinum toxin has already been introduced by Dr. Khullar has explained very nicely. And usually for overactive bladder, we use 100 units diluted in 20 ml, and we use in 20 sites. And we can repeat it at 12 weeks. Replace I with V, because then only illness becomes wellness. And fact is that actually it was introduced by Dr. Philip Bozani in 1805, but the visualization was improved by a gynecologist, that is Dr. Howard Kelly in 1894. So present recommendation as by Accreditation Council for Graduate Medical Education is that cystourethral training is required by all OBS and Gyne residency programs. So that's the thing. With this, I conclude. I will say that there is no fight between urologist and obstetrician or gynecologist because a candle loses nothing by lighting another candle. So we must actually teach each and everyone to know what is better for the patients, not for the ourselves. Thank you so much.
Thank you so much. Excellent videos and excellent presentation. No words to praise, madam. Very nice videos. And really the debate of cystoscopy to be done by us or not is same like sonography initially to be done by gynecologist or radiologist. Ultimately, the founder of sonography was also a gynecologist, in fact. Anyway, we are running short of time. Excellent, madam. And I think we can't allow the questions because we are awaiting panel discussion, which is really awaited by our viewers.
Really excellent, Dr. Amita. Really excellent.
Yeah. Thank you.
Over to you, Kajal.
Excellent and beautiful videos, madam. Amita, ma'am.
Thank you so much.
Yeah. So, moving to the last session of this webinar, case-based panel discussion on dealing pelvic pain with and without uterus. So, I would like to invite the moderator, Dr. Vidya Bandukwala, madam. She is a founder member of Female Pelvic Pain Association. She is a core member of GIBS, consultant gynecologist at Nanavati Hospital and Saket Hospital, Mumbai. Welcome, madam.
Thank you. Thank you. I think we've witnessed the speakers, and virtual platform does not allow us to have a coffee break, but I'm sure with the comfort zone, we all can sip over a coffee and go ahead with our discussions. So can I introduce the panelist? Dr. Kajal?
Yes, ma'am.
Yeah. So we have excellent panelists with us. We have Dr. Tejal Shah, who's an obstetrician and a gynecologist at Prime Arkit, Surat. She's also affiliated to Lokit Hospital at Surat. Welcome, ma'am. We have Dr. Praful Doshi, who's the director of Me and Mummy Hospital, along with he's the consultant at Blossom IVF Center, Surat, and a professor in Gynae in the Medical College of Jamnagar and Surat. Dr. Praful, are you there? Dr. Praful?
Yeah, I'm here. Yes.
Yeah, welcome, sir. We have Dr. Ranjana Sharma from the North Zone. She's already been introduced. She is a senior consultant and also a chairperson of the AICC RCOG North Zone. Welcome, ma'am. We have a pain management consultant, Dr. Navita Purohit, who's a core member of the Global Interstitial Bladder Pain Society, and she deals with the rehabilitation. Yeah, and she's a consultant at Kokila Ben Dhirubhai Ambani Hospital. Dr. Navita, are you around?
Yeah, Dr. Vikram. Thank you.
We have, we have Dr. Saral Bhatia, who's an associate professor of OBGY and in the department of OBGY at Government Medical College, Surat. Dr. Saral, I welcome you.
Good evening,
Dr. Meera, has she joined in?
Okay.
Chester?
Hello.
Dr. Vidya, I'm
Yes,
here.
ma'am.
Thank you.
Yeah, hi. Thank you so much for your last minute. Yes, it was really crucial because we had Dr. Tamil who had an urgent issue. So Dr. Meera is all the way from Chennai, and she is, can I get the slide back? Chester, can I get the slide back?
Yes, ma'am.
I do not want to spend too much time introducing, but she is a senior consultant urogynecologist and a robotic surgeon at Apollo Hospital, Chennai. Thank you so much, Dr. Meera, for accepting our invite.
Always. Thank you.
Okay, I'll share my. Are you able to see?
Ma'am, you have not shared it.
No?
Not able to see, ma'am.
No?
Yes. Yes, ma'am.
Yeah. Okay. Now, without wasting too much of time, I think we had an excellent talk from Dr. Vikram. We had an excellent talk from Dr. J.B. Sharma. Wonderfully explained the SUI surgeries. And Dr. Amita, you killed it with all your videos. I think no words to appreciate your work on that. lovely presentation of the cystoscope and the different conditions where we need to use the cystoscope. Thank you very much. Now we go on with the chronic pelvic pain. It's a case-based discussion with pain as a parameter, which takes us to the, I'm not going to introduce chronic pelvic pain because I think Dr. Khullar did a wonderful job. So let's get to the case. Yeah, this is a case of a 29-year-old unmarried working girl. She came with a complaint of pain in the lower abdomen and the pelvic region. Her main complaints were exacerbation during the menstrual phase, and the pain has been more in intensity since last 2 years. She's been to a lot of doctors. She gets temporary relief, but back again with the symptoms. And the intensity keeps worsening when she does her routine work, and hence she has to take a leave from her work. So her quality of life is completely compromised, and that is the reason she's come back to us. She is sexually active and she gives history of dyspareunia. There was no complaint from the vaginal side. She had no vaginal discharge or any other vaginal infection. No bowel habits that were irregular. She had absolutely regular bowel habits. But asking her about her urinary symptoms, she said, yes, she does have frequency, urgency, and those are pronounced in the menstrual phase. And she also complained of small voids. So I think with the panelist, do we need to ask anything more beyond what has been spoken right now? Dr. Saral?
Yes,
So you are.
Yes, yes.
Yeah. Would you at this point probe into anything else? Because I believe that in chronic pelvic pain, we need to know the history in detail.
Definitely, madam. I would like to know whether the site of pain exactly, the site of pain, the aggravating factor which are associated pain, the relieving factor which are associated with pain, and actually the type of pain, whether it is acute pain or dull aching pain.
Absolutely.
And associated bowel disturbances are associated or not, and specific history regarding bladder disturbances, the duration in daytime, nighttime, and whether it is associated with the menstrual cycle or not. So we can rule out endometriosis or adenomyosis, etc.
So great. So I think we have covered up all of them. If you go, only the pain has not been asked in detail. We'll come to that, sir.
Okay.
So as far as the pain, what you said was absolutely right. Yes, she had varying intensity from dull aching to sharp burning pain, radiating to the entire vulval region. Some relief was there after voiding. So this is a very typical history that we need to note. She did give history of superficial dyspareunia. So there was a discomfort that she did mention about the sexual intimacy. Her quality of life was disturbed. She was depressed, poor sleeping habits, inability to work, loss of libido and relationship issues, scared to socialize because of the need to use the washroom. Dr. Meera or Dr. Ranjana, would you like to point out on just the quality of life, why does it matter most in our history?
Definitely, because the quality of life gives at such a young age the impact and the chronicity of the illness and the problem itself. And she's obviously visited too many specialists before arriving on our desk, and not wasting too much time and getting to the bottom of the things is what she wants to achieve at this point of time. And many of them could have reached a central sensitization point as far as the pain is concerned.
Yes.
So we need to address the pain aspect straight away.
Absolutely. Yes. I think, Dr. Meera, you said it very rightly that, we have to look at this patient who's visited so many doctors, and she's now come for an answer to her pain. So all these matters a lot, and especially the quality of life. With a personal history, we got to know that she is a smoker, but a social drinker. Family history, she said she had a very supportive family history, which is very, very important in counseling these kind of patients. Now, Dr. Saral, you pointed out very clearly with the pain. And
Yes,
now we go forward with the past history. So Dr. Praful, does the past history really matter when we take a history for chronic pelvic pain?
Yeah, we have to know whether the periods were always painful, whether her mother also had painful periods where she has seen her suffering during menstruation, and that is sometimes woven into her psyche. So
any other history you would like to know, because she's come with pelvic pain with a lot of treatment being taken and still no relief. Anything in particular you would like to know beyond?
I don't think so. We would always, of course, we will know the amount of drugs or antibiotics that she has taken, and we will try to rule out certain things from, if those treatments did not help, then you have to rule out that diagnosis.
Absolutely. So she did have regular moderate flow, painful for 2 days, but tolerable. The only thing is she said that since 4 to 5 years, the intensity of pain was getting severe, and she perceived the pain beyond the cycle for almost 10 to 12 days. Now, this is something that we need to address, is that her pains were not just going around the menstrual cycle, but it was going beyond it, and that was troubling her. We probed into her past history, and she did give the history of having an endometrial cyst excision 3 years back. So something to now witness is she's already had an endometriotic surgery, and we know that she was being treated for her endometriosis. She's taken GnRH suppression, she's been on continuous OC pills, she's been on Dynogest, and all of these treatment was taken haphazardly because I think she's fed up of taking medications and there is no answer to her pain relief. She's had similar episodes of pain exacerbation with urinary symptoms of frequency, urgency, which way back from her 10th standard exams is what she remembers. So past history is so much needed, because probing into her past is what will give us an idea of what we need to manage her with. And she did tell us that she had these remissions and flares in between, but I don't think she realized that was a matter, because the pain was overshadowing her urinary symptoms. And she kind of got adapted with this kind of urgency and frequency, and she didn't think it was relevant to talk about it. It was only after probing that we realized that she did have urinary urgency and the frequency. So there were no other past medical history and no history of any physical or sexual abuse in childhood. Dr. Ranjana, why would we want to know about her abuse in childhood? Does it really?
So pain is a matter of perception, right?
Right.
So how you perceive a pain, and lots of times, the problem is something different, but it manifests in a different way. Patient will come to you with a pelvic pain. She actually herself doesn't know what's going on, and this, in her mind, sexual abuse is in the history is very, very important. And we have to take patients into confidence and take this history, because this will color them. So they are their sexual life is disturbed, and then it adds to this problem. The pain becomes even more. And then the pain has been there was some pain, and now the sensitization of an organ. So a little bit of pain also becomes too big for her. And sometimes even the pain is not there, but she knows that she can't get that out of her mind, that it's there. So so lots of that's why we have to tackle this pain at multi levels.
Absolutely,
right?
absolutely, ma'am. And studies have shown that the sexual abuse in childhood they are the ones who have survived the abuse, and they are the one who land up with chronic pelvic pain more often than others. So I think this is a very relevant history. I go back to Dr. Meera or Dr. Saral. Is what is this adaptation behavior that most of these people do? They I mean, here we have a patient who's come with pelvic pain and gives a history of endometriotic cyst excision, and we are completely thinking that this patient is an endometriosis patient progressing in her condition. So how do we then say that, do we consider that she also has a bladder endometriosis at this point? Does this history go with that?
No, probably what is happening is she converts her pain of bladder filling as a sensation to empty the bladder, and maybe projecting it as a urinary frequency or a urinary sensory urgency, so on and so forth. It's kind of a displacement reaction, might present as depression, might present as somatization, might present as radiation of the pain, or even an affective disorder, and could be attributed to the way it's said in the history, it's affecting the way she's socializing as well because of her washroom habits. So the pain might have been the trigger for the exacerbation of her toilet habits, and looks into a detailed probing into that so as to detrain the way she's been manifesting the problem.
Very well said, Dr. Meera. So I think we also have to realize that as gynecologists, the pelvis has the lower urinary tract, the gastrointestinal system, the musculoskeletal, as well as the neural pathway. So there is a crosstalk. There is a pathway of the nervous system which is common to all three of them, and hence any one disorder can be manifested as pain or symptoms of another system. So it's very important to know the anatomy of the system. So as we go ahead, why would we want to know the most bothersome symptoms? Would that change our management? Dr. Praful?
Yes, we would try to concentrate on that part first. And sometimes by treating the one symptom, the other symptoms get automatically corrected. You don't have to give multi-therapy at a time. So whatever is the dominant symptom, you tackle that.
Yeah, absolutely. So I think the most important part is to know what is bothering her more. Is the pain or the urinary symptoms? Like in a patient with the overactive bladder would actually come with only urinary symptoms. But a patient with the pelvic pain would definitely want the pain to be the most important complaint, and the relief of pain is very important. So let's get Dr. Navita now that we are speaking about the pain. How relevant in your history taking is pain, because you manage pain day in and out?
Yeah, very rightly said, Dr. Vidya, because history taking is the most important aspect, followed by clinical examination, which takes us to what can be the provisional diagnosis and how to go about it. Because if we know what is, as in this, that in this case that she has a burning pain and there is a pain in the suprapubic and the vulval area, and we know that it started 2 years, so it's a chronic pain which we are dealing with. So what to start when they come, when we in our history, we just start that right from to create that cascade right from the history taking. So, and what is the score? What is the correct? What is the severity? Because what whether to start directly on the pharmacological management and what to start, because if it is a mild pain, we can manage with any analgesics like a paracetamol, or otherwise if it is into moderate to severe, then we'll have to start some milder opioids. So and even knowing what makes it better, or what are the relieving factors, so we can at least tell them that to change their lifestyle, because lifestyle modification is also very important when we deal with the history. One thing more important is that in this case, I would like to comment on, and I would like to ask what exactly does she, what is the nature of her job? Because if she has pain in the lower part and if she sits for a longer time, then if she has in this scenario, if she's working on a laptop for 8 to 10 hours a day, then again that will increase the pain. And then when we say it's a urinary, it's a vaginal, then MSK is involved, the nerves are involved. So the MSK pain would be more when they sit for a longer period of time, and she's on absenteeism. So it's very important asking all these questions, and dyspareunia, the whatever the treatments they have done, and also important is the family life, as you have already told, that the family support, she has a very good family support, history of sexual abuse. night sleeps is very important, because again, this lady has some small voids, but frequency is more. Then if that is disturbing, is the pain disturbing the night sleep or the urine? Because just before this, the question was what to specify on, whether pain or the urinary symptoms. So both, I think so, is important, because if the pain is not letting her sleep, then we have to give something. And if the urine is not letting her sleep, then we have to think in that aspect. So yes, and then she's depressed. So all these things, the history is the most important aspect, which takes us to the provisional diagnosis and where to go on from this.
Okay, I think you covered up very well, because we all need to know that chronic pelvic pain is multifactorial and everything matters. So when we look at these patients, we need to look at the conservative line of management along with the stress management. And what you said was the job profile of the patient. One is not just the job of sitting, but also of the stress management, whether she's really stressed with her job profile or no. So all that matters a lot. Dr. Tejal, would you like to put some more focus on the pain, or do we go forward? Dr. Tejal? Is she with us? Okay, so I think when we speak about pain, we get a lot of understanding from the pain history.
Dr. Tejal is muted. She is speaking, but she's muted.
Can you ask her to
unmute yourself, Dr. Tejal? You have to unmute yourself. Yes.
Tejal is on a break. Yeah, Dr. Tejal.
No, I hope you can hear me now.
Yeah, now we can hear you, Dr. Tejal.
Yeah. So I think almost all aspects have been covered, but her dietary habits, her water intake.
Oh, lovely.
I would also like to evaluate this. I would like to add that in this. So I think that would make the complete history taking.
Yes. So her intake is very important, and what are the kind of fluid that she takes? It's very important. Dr. Tejal, you pointed out very well.
Thank you.
Okay, so we go forward. As much as history is important, even the examination is very, very important. So looking at her examination, Dr. Praful, what are you fine with the examination that's mentioned here?
Your voice is going.
I think other panelists have to mute because what is happening, there is an echo.
Yes. Tell me, what did you say?
I said with the clinical examination, when we deal with pelvic pain, we look at the history and we look at a detailed physical examination.
Yes.
So what would you do for a physical examination? How would you begin with it?
For physical examination, you start with the rest of the things. You have, of course, vitals and other things I don't go into. Well, we presume it is good. But we start with the abdominal examination from above downwards, starting from the upper abdomen, the renal fossa, the suprapubic area, and then go into per-vaginal examination and per-rectal examination also. And then look at the findings, tender points, any masses. These days, I don't know what others are doing, but we do PS examination and straight put the transvaginal probe for any such these things. We have almost done away with PV examination. But yeah, per speculum examination is important. And
you actually, Dr. Praful, you pointed out very clearly that these days with the transvaginal probe, we hardly do any per vaginal examination. So I think when we meet a patient who's come with a chronic pelvic pain and who's already been with a number of doctors, the least we can do is after a per speculum examination to actually do a per vaginal examination. So I think this is a take-home message that these are small things, but these need to be done for these patients. So if you look at the systemic examination, also Dr. Vikram today mentioned about fibromyalgia and the trigger points. So I think we must get into those kind of history also. I'm sure Dr. Navita is nodding and saying, yes, you need to know the trigger points and the 18 points that are important. So I think that was a good take-home message from Dr. Vikram.
And Vidya.
Yeah.
So when you do,
I think this.
Sorry. when you do TVS straight away, you miss out on the rings, spasm rings.
Absolutely.
Also miss out on the spasm of levator ani. You also miss out on the superficial or deep pain. You want to know the trigger points, exactly what you say.
Yes.
So
very, very
Ranjana.
Yeah, ma'am.
So what I want to say here, because this patient is quite a different patient. See, she has had history of sexual abuse in the childhood.
No, she's not given history of any sexual abuse, madam.
Sorry?
She's not given any history of sexual abuse.
Okay.
We just wanted to rule out.
Okay, you wanted to.
Yeah.
So, all right. But this patient has been suffering with pain for a long time, and probably interstitial cystitis also, we don't know. So this patient, first, you have to be have to examine with empathy.
Absolutely. You nailed it right, madam.
Yeah. So you have to,
yes.
You have to take her into confidence that your examination is not going to be painful. So see, sometimes, how many times patients have come to me and they have said, oh, this examination, they dread this pelvic examination. And I tell them, pelvic examination should never hurt you. It should never hurt you. And if it hurts, actually, we know that we are at fault. So, sometimes you don't know the direction of the vagina and you push the speculum in a direction where it will never go inside. This is not so if you are finding a little bit difficulty or you're not in the right direction, put your finger gently first in. You know what the direction of the vagina is. So what the bottom line is, whatever I'm saying, that you cannot give her a painful examination.
Yes, I definitely agree with you, Dr. Ranjana. I think that's so true, because even a speculum examination can trigger the pain, and she may probably not allow us to do a PV exam.
And if you don't rush, you have time, you take time. No speculum examination is hurtful.
Yes.
You choose the right speculum, right size speculum for the patient, and do gently. Take your time. Let her relax.
So
you cannot win. You cannot win if the patient is not relaxed.
Absolutely. So you should not be forceful in your approach. You should be very empathetical, because we are dealing with a very, very depressed woman who's come for an answer.
Sensitive.
Absolutely.
You can use Gynocal.
Yes, madam. Absolutely. Because this is what we want her to feel comfortable.
I read that is Gynocal and then examine.
Okay, but ma'am, if you inject, you may not be able to get the trigger point. So I would say not really inject at this point of time, because we need to know the spasms, and that part of the spasm will be lost if we use
more than anything, you need lubrication.
And we can use a KY jelly for that matter. So we go to
the other point is sorry,
Dr.
I would like to make a point. Sometimes you hand over the narrowest speculum or a very small size speculum to the woman, ask her to insert herself.
Yes.
Relax the bottom on the bed.
Absolutely.
And that will give her the confidence she's able to bear. See, most of these cases of vaginismus or vulvodynia are probably during intercourse, but they will allow digital examination. They will say that.
Yes.
And second point about the transvaginal ultrasound, it is quoted as an extension of the gynecologist's hand, not as a replacement of the gynecologist's hand. So that is something we need to be wary of.
Very, very well done. Now, when we did a local examination with the Q-tip test, we did get a provoked feeling on the minimal touch. Query, again, I've written query because we don't know, we have to do a diagnosis of exclusion. On per speculum examination, her cervix was healthy, vagina was healthy, but there was mild to moderate resistance seen on the speculum insertion. Now, again, as both of the doctors, Dr. Ranjana and Dr. Meera said very clearly, is one, in such patient, you have to build up a rapport with the patient first, get her confidence, ask her whether she will be okay for this examination. There has been times when these patients do not allow examination, and you may have to ask them to come back to us, and we may have to do this test on another day. So it's very important for us to make her comfortable and then go along with these kind of examinations. On pervaginal examination, again, after taking her consent, a single digital palpation was done. Again, as Dr. Ranjana said, it should never be a forceful and it should not cause more discomfort to her. And so this was done exactly that way. Her uterus was retroverted, normal size and mobile. Fornications were clear. Anterior vaginal wall discomfort was felt on palpation with resistance, followed by a reflex tightening of vaginal spasm. Dr. Saral, would you like to put some light onto this kind of examination? Like we know in her past she's had endometriosis. Now, do we look for anything when we look at an endometriotic patient on examination? You're muted, Dr. Saral, you're muted.
I would like to, there may be any presence of fornicial tenderness or any mass palpable on fornices to rule out endometriosis, or there may be any pain felt on anterior fornices if there is any bladder infection, so we can rule out any interstitial cystitis, etc. direct. So it may be helpful to rule out either bladder infection, or based on the history and examination, there may be presence of endometriosis or recurrence of endometriosis.
Absolutely. Dr. Tejal, would you like to add anything more, or do we go forward? I think all of them are muted. Please unmute while answering. Okay, I go forward. I do not want to.
I think endometriosis was the basic diagnosis, and if that could be ruled out, we have to also keep in mind the diagnosis of vaginismus or vestibulitis in this patient.
Absolutely. As Dr. Meera was saying about the somatization, sensitization, I'm just trying to show that what are the organs that we have to look in while doing a per vaginal, per speculum examination. How one system can hamper the working and functioning of the other system is well picturized in this pre-examination review. So let's get to the investigation. What are the investigations that we would really like to look upon here? Dr. Tejal or Dr. Praful? We already know that this woman has been to a number of doctors, and we do not want to go back to the same test again and again. So what are the basic tests which we would like to look upon when we are trying to exclude the diagnosis that we are looking into? We are trying to narrow down the diagnosis at this point. We have a lot of things now challenging us. So we have vulvodynia, we have vaginismus, we have endometriosis, we have query, ICBPS, and there are a lot of other things which we haven't even touched upon. It could be fibromyalgia, it could be a pelvic floor dysfunction. So how do we narrow it down? How do we get to the single entity or maybe something overlapping? So I think in this case, since we did not want to probe too much into her, we just asked for a basic complete blood count, a urine routine and culture to rule out any kind of infection at this point of time. We must always rule out infection because she could be having n number of pains, and every time that she comes, she may just about have a urinary infection the time she sees us. So we must rule out, and we must always ask this patient for a midstream because there's a lot of contamination when they are not asked to do that.
Yeah, a properly collected midstream sample.
Absolutely, Dr. Tejal. I think we as physicians should kind of tell the patients how to collect the urine. This is something we don't do in our routine practice. We must tell them that the midstream is what is needed. They need not do.
It makes a difference. Yeah.
Yes. They need not do a morning void. They can just give their urine at any point, except that they do it rightly. Why would you, Dr. Meera, want to do a transvaginal ultrasound here? Dr. Meera, can you unmute yourself? Dr. Ranjana, would you like to answer this?
Yeah, so she gives a history of ovarian cystectomy, endometriotic cyst removal in the past. So that diagnosis is with us, right? So we would like to see whether she's developed more cysts, and So we would like to see the status of the ovaries.
Absolutely.
And
Yes.
also if there is any new development in the uterus and in the pelvis.
Absolutely. We know that endometriosis is a progressive condition. So we really want to look upon whether she's gone into from mild to moderate or severe category. Again, at this point, we would definitely, with all her urinary symptoms, we must know whether she's got any significant post-void residual volume. And that is the reason we asked for it. Food and bladder diary. I think Dr. Vikram was very clear in our understanding that food can be one of the most trigger factor for pelvic pain. And he did mention about chocolate, tomatoes, any citrus food is a matter of concern, and we need to know that. Would somebody want to give some light on bladder diary?
Definitely.
Yeah, Dr. Meera, would you?
Yeah, bladder diary is different from frequency volume chart in the aspect that the frequency volume chart just takes into account how many times you use the washroom, how much you put out. Whereas a bladder diary over a 24-hour period, ideally we need 3 days. It can be random 3 days and not necessarily consecutive 3 days. For a bladder pain syndrome patient or a chronic pelvic pain, I tell them to keep it on a normal day when they have a working day and probably a weekend or a feast day, so-called a treat day when they're having to look at into exacerbations of the issues. So they need to document from morning 6 o'clock to the next day and also include the first void of the morning into the previous day's account and take into account how much they've drunk, what all they have been drinking, the quantity of it, how many times they have been visiting the washroom, how much they have been putting out, whether it was associated with the sensation of pain, urge, leak, and what they were doing at the time, and also note down leakages. So this will not only give us an idea of the diurnal variation of the frequency, it's a straightaway understanding of whether the woman's bladder capacity, what we call functional bladder capacity, is good, whether she is going at the first signal when the bladder is even filling up, what we call the first sensation to fill. So in women, usually the capacity is 400 to 500, but these women with a sensitive bladder, so-called, will be going at 50, 100, so on and so forth. So straight away as a stopgap, it is giving us the diurnal variation, the amount of urine output, whether is it in synchrony with the input, the number of visits, and whether it is a sensitive bladder, and an idea about the functional capacity.
Very well said, Dr. Meera. I think, yes, the bladder being a simple tool can give us so much of information. So I think if you actually go to see, we really not ask for too many investigations, but even with these small investigations, we can understand so much about a patient. Dr. Navita, when you ask for a pain score,
someone is asking about Q-tip test as well.
Yeah, we'll come to that. We'll come to that. Dr. Navita, when I say about pain score questionnaires, can you elaborate about the questionnaires that you would like to know from your patient?
Yeah, so there are, pain is subjective and we cannot, there is no objective test for the pain. But yes, there are some questionnaires which can tell us, like McGill pain score, or we can, the simplest is the numeric rating scale or the visual analog scale, in which we just tell the patient to score their pain between 0 to 10. 0 means no pain and 10 means the worst pain ever. If the patient is not able to say, then there's something called as a facial scale, in which you can show the faces and whether the smileys, which are whether the face is smiling or there is no smile, or there is a crying, or just like a not so happy. So depending on that they can be categorized into mild, moderate, and severe. And also the more questionnaires like the McGill, what I'm talking about, McGill pain questionnaire. So this is NRS, VAS, and these are regarding the severity of the pain. But what is the character of the pain? These also have the character, and what is the diurnal variation, the radiation, and the location. Is there a referred pain or a radiating pain? And there's a body part in which you can give that to the patient, and they can actually mention on that, or on the cartoon where exactly is the pain. so we know more about it, because sometimes they are not able to tell where exactly is the pain. So then that cartoon will tell us, when they mark on that cartoon, that starts from here and then comes down anteriorly or posteriorly. Then character and also the quality of life is also included in those questionnaires, whether we can know that everything from these questionnaires we can find out regarding the severity, the intensity, the chronicity, and whether it's a neuropathic or a visceral or a somatic pain, or it's a chronic, so we know the sensitization has been done or not, and also what is the mood. And other there's something called as widespread pain scale, so in which we'll know that there are other somatic symptoms like acidity or bowel habits. So that will these are so these questionnaires they are validated, and if we use it in our day-to-day practice, we'll be able to know and then start the management from as a pain physician to how to go about it. So these things tell us about the quality of life as well.
So I think you correlated very well that along with the pain, the quality of life is also judged at the very go with the investigation. So I think Q-tip test, yeah. Dr. Tejal, would you like to speak about it?
Well, the Q-tip, it exactly points the points of the pain, the most painful, where a cotton swab on a tip, as the name suggests, is pressed on different parts, like around the vulva, and the pain elicited.
Yes. So you look at whether there is any provocation with the touch of the cotton wool, and it is diagrammatically drawn. It can give us an understanding about vulvodynia, vaginismus, whether it is a provoked or unprovoked. All these understanding can come in the Q-tip test, and it's a very simple test. It just needs a woolen cotton wool tip on a.
It will be like charting of the patient's complaint.
Charting. So I think when we look at pain, a diagrammatic mapping of the pain and the understanding of the intensity, severity, radiation, all this will be covered up with the questionnaire, as Dr. Namita pointed out. So at this point, do we want to go to invasive techniques, or do we only go with the investigations that mentioned here? Dr. Saral, would you like to now plan anything invasive before starting with the management, or would you? You need to unmute.
I would definitely I would like to conservative management first.
Absolutely.
Based on the history and examination and investigation, we will definitely go for conservative management first. If it does not respond, then we have to think regarding any invasive procedure.
Very well said, Dr. Saral. I think any role of invasive management is not there unless you don't do a conservative understanding of the disease. So cystoscopy, again, at this point, I don't think we should talk about it. Let's go with the investigation reports. The complete blood count was a normal study. There was no infection, no growth seen in the urine. What does this tell us, Dr. Praful?
Sorry, tell me again.
What does this say when we say that there was no growth seen in the urine? What? Yeah.
That means the urine is sterile, no growth seen in the urine. Most of the time what happens is these people have taken too many antibiotics totally unnecessarily, and as someone said, that midstream technique, or sometimes when the persistence of pus cells like just 10 to 15, I consider is absolutely normal. And I take a catheter sample at that time just to make patient believe that there are no pus cells, there is no growth, and then relieve her of all the antibiotics. So many times these patients are so anxious that their infection is not getting cured, and a lot of functional element in the pain or frequency comes in. So when they are assured by the reports that there is nothing wrong with their urine, then so many times their symptoms are relieved.
Absolutely, Dr. Praful. Assurance is very important to these patients, and I think we need to tell them that there is really no infection, and the pain is related to some other organ which we need to deal with. So her ultrasound showed a normal size uterus. Her right ovary was enlarged, and there was a 3.8 centimeter endometriotic cyst. Dr. Meera, do you think this would be a cause of her significant pain that she has been complaining of?
Not necessarily. It might be an incidental finding, might be an exacerbating factor, but also gives me as a pointer to look out for the coexistence of bladder pain syndrome, which in various studies have been coexistent along with endometriosis. So it probably, if I'm undertaking an invasive procedure, I would have to combine a laparoscopy and a cystoscopy with a therapeutic intent, not with a diagnostic intent.
Perfect.
The other point is, if I am thinking in terms of bladder endometrioma, which could also coexist, that is another reason this would be pointed towards. And this patient, I understand, is a smoker, so we'll have to keep those points in mind.
Absolutely. So since she is a smoker, the role of smoking is there in the bladder that we will see. The bladder was well distended with pre-void volume of 200 ml and post-void being 15 ml, which is hardly significant.
More than the urine no growth, I'd be interested in looking at the urine microscopy and the cytology to look for any microscopic hematuria, where this aspect of smoking comes into.
Yeah, very good. Well, with the food, she did recognize that intake of spicy food did increase her frequency. And I think the talk before with Dr. Vikram said, he spoke about chilies, the role of chilies and the pain. They trigger with the chilies. So let's come to the bladder diary. She did show increased daytime frequency urgency to the tune of 12:4. That means her daytime frequency was much more than the nighttime and followed by a small void. Does this lead us to our diagnosis now, Dr. Tejal? Are we looking into?
Yeah. So rather than some organic, am I audible?
Yes, yes.
Yeah. So rather than some organic thing, the stress factor and the personal factor comes into being. Because had that been the causative cause been infection, then nocturnal frequency, daytime frequency, both would be more. But here, while she is awake, the diurnal frequency is more. So psychosocial factor may be more important here rather than a specific factor.
Absolutely.
So we'll have to concentrate on her stress factor and her thinking more. So I think she would benefit more with patient listening, maybe a psychiatric counseling along with the therapeutic measures that we are going to administer.
Yes. So I think
having said that, for a young girl like herself, the frequency of 4 in the nighttime itself is quite high, which is causing a sleep disturbance. If somebody is woken up from sleep, it's very important to undertake the fact that it is either the pain or the bladder irritability which is keeping them awake. So it classically shows she is suffering a lot from the disorder.
So I think in a patient, if we are looking at IC, we have to ask her whether the pain was the reason that woke her up in the night, or was it the urgency frequency, the urge that asked her to, wake up and go to the loo. That is a very important talk that we need to have with her. Well, as we said that this patient till date was being looked after as an endometriosis and was given suppression. So we have to understand that in a patient, we could have two coexisting conditions, and that is why this case is brought forward. And we need to now get into a detailed understanding of our ruling out IC-BPS in this patient, and that is where we wanted a bladder diary for her, we wanted a pain score questionnaire for her, and we wanted an ultrasound. So she is probably having a coexistence of endometriosis and the IC-BPS. So when we come for a differential diagnosis, I think what we normally look at is we look at endometriosis with the younger age patients. We always want to rule out any pelvic inflammatory disease. We want to look into recurrent UTI. We want to look into vaginismus secondary to pelvic hypertonicity. I think Dr. Vikram very well said that pelvic floor dysfunction is a major cause of chronic pain, whether it is a consequence of the disease that is going in the pelvis or it is a part of it. So we need to know that pelvic floor dysfunction, being a case of endometriosis, we should also consider adhesions as a part of her pain factor. Again, we need to rule out whether she's got overactive bladder or it is plain IC-BPS along with endometriosis, or it could be, as Dr. Tejal said, it could also be a psychosocial element at this point of time, or it could be vulvodynia or vaginismus. Dr. Meera, at this point, what would you still consider going with the history and the investigations? What would you narrow down to? Dr. Meera, I think you need to unmute. Dr. Ranjana?
Dr. Ranjana just left Vidya because she has to join.
Okay, so I think we have these conditions that are all showing that we could have overlapping diseases in a individual, and we need to understand that if we have a patient who has been treated for endometriosis time and again with suppression of hormonal therapy being given to her and it's still not comfortable, then we need to think out of the box. We need to now know that there is another element, and that could be the bladder, it could be the gastrointestinal, it could be the pelvic floor dysfunction, or it could be just a neuronal crosstalk that's giving the patient discomfort. And so I just want to know that as gynecologists, let us not be stuck to our reproductive system, but we understand that the gastrointestinal system as well as the musculoskeletal and the urinary have much more in the evolution of the pelvic pain. So let's see what are the overlapping features that give us physicians a challenge. Is the pelvic pain, which is common to both. Again, Dr. Vikram was very clear in the immune response, the innate immunity that is disturbed in these kind of patients. And that's why they have this typical, endometriosis implant, which we normally don't see in other patients, and why in these particular patients. So these patients are the one who have pelvic pain, they have dyspareunia, and the consequence of that is an impaired quality of life. There has been no infective source seen in both the conditions. It's always been an inflammatory immune response that we have seen. Both have a very progressive condition, and because of the delay, we see them sometimes in a late stage. So again, the same thing that, and the goal of this whole treatment and management should always be pain relief, and it also needs to be multimodal approach. I think Dr. Navita, how many cases of endometriosis and ICBPS would you see if you may have seen patients in your past where the patient was sent as endometriosis, and probably over the period they must have realized that this is not just endometriosis and this is ICBPS, and there is involvement of the pelvic floor. They all have hypertonicity. I'm sure you have examined these patients. So how frequently do you come across these kind of patients?
So with endometriosis and ICBPS, quite a few which we come across means they go to a gynecologist, but they come to me for the pain, and then when I ask them, they do have some urinary symptoms, so I send them to a urologist as well. And even sometimes it's just that they come for some abdominal pain, all the investigations are fine, and they come to me with some myofascial, but then on again probing, they do have some urinary symptoms. So they do have quite a number of cases. They do have both existing coexisting. So I think so it's really very I have also seen, so I'm sure you must be seeing more than me, because
so it is a dilemma. Yes, it is a dilemma for all of us, so where sometimes we are actually treating the patient for endometriosis, and over a few weeks we realize that, oh, there is something else to deal with, and we realize that the patient has another symptomatology that needs to be addressed. So let's go. Dr. Meera, would you like to highlight on this slide now that we've come to ICBPS? Dr. Amita, would you come in?
Okay, Dr. Vidya, we are talking about interstitial cystitis, which is actually a disease where there is a damage to the inner layer, that is glycosaminoglycan layer of the bladder epithelium, and because of that there would be certain changes. It's a kind of leakage into the interstitium, so that's why irritants are inside, which are causing mast cell activation, and this will lead to both the things. There would be immunostimulation as well as there would be pain fiber, that is C fiber activation, and all these things actually aggravate. This is a kind of vicious cycle, which will cause more insult and damage to the epithelium, and this will in turn lead to the other dysfunctions as well, like you can see in blue marks, pelvic floor dysfunction. As I told in my lecture, that because of the pain, the pelvic floor spasm can occur. There are things which are actually causing the things like autoimmune response, infection, chronic infection. Recurrent infection can cause damage to the epithelium. It could be a neurogenic origin as well as, and sometimes any kind of trauma, any surgery in the bladder, or over distension even during the cystoscopy. Even after delivery, there are cases when post delivery retention is there. All these things might lead to damage to the epithelium and origin of interstitial cystitis. So that is
very well said. So any defect in the protective layer of the bladder, we must look into this. This is a cascade that then deals with the leakage of the irritants going into the submucosal and triggering all the factors that Dr. Amita elaborated. So how do we go into this approach? Dr. Tejal, would you go, you have a patient who's come to you, she's absolutely depressed and her quality of life is in a bad shape. How would you go about? You would still want to treat her by yourself, or now you would like to take the help of your colleagues at this point? Because we know that there is multiple factors that is involved. There is the...
No, she definitely needs therapy from a team rather than from just me. While I would handle the gynec aspects of the necessary drugs, she would also need some counseling, some psychiatric consultation and treatment, some physiotherapy also. So I think a combination of everything plus a very good advice on regular lifestyle. I think all this is going to pull out the patient from this present situation.
So I think, Dr. Tejal, here we need to have a good rapport with the patient. There has to be a strong bonding and understanding to create that kind of a scene, because she's already fed up. She's been to so many physicians and she's not relieved. So she has to feel that her story has been heard, that there is nothing in her mind and she's actually suffering. And once you get that relationship with this patient and you give her a realistic understanding that this pain will be addressed and it will take weeks to months to understand, and there will be a necessity for her to meet other colleagues of our specialty, other specialties, so that we are able to work together and simultaneously treat her pain. So we have to get her understand. So it is patient education, conservative management. Very well said that we have to do a behavioral modification. There are patients who are very anxious, so we need to calm them down. There are ways of doing it by counseling. In India, it's lacking, but we as gynecologists now have to learn newer techniques of getting to understand these conditions and work with our patients. So we have to get her to understand her condition, help her in getting a self-care strategies by cognitive behavioral therapies. There is no single effective therapy is what she has to be told, and she needs a multimodal, multidisciplinary with realistic goals. And again, as we said, that we have to go along with our other specialties. So Dr. Namita will be here to help us with the pain management. We need to start her with basic pharmacotherapy to take care of her pain. We need to have a psychological assessment and to know what is really worrying her, and then help in a physiotherapy such as physical therapy. So again, this is the stepwise treatment of IC-BPS patient. And I think there is more understanding. If somebody really wants to get into most understanding, then there is the GIBS website, which can give us more details. Again, as Dr. Ranjana pointed out, that when we are evaluating such patients, you have to do it in a very soft manner. We need to speak to this patient, and then you can elaborate the anterior vaginal wall or the bladder-based tenderness. You can look at the levator muscle spasm and rectal spasm. I think, Dr. Namita, can you put a little light on these examinations where you actually see the levator muscle spasms?
Yeah, so it's very important. Yeah, absolutely. So they do have a pelvic floor spasm or dysfunction, and when we do the single digit per vaginal examination, so we have to go according to means we have to examine right from the superficial to deep or anterior to posterior if we see. So we have to, at all the pelvic floor muscles, we have to examine that where exactly is the tenderness. Then we have to, it's in the, it's just like when we, this is what I do, that when we get some tenderness, whether it is in the just like a clockwise manner, it's a 3 o'clock or 6 o'clock position, it's a deeper inside, or it is just superficially, and we can actually see whether it's not only the levator ani, but also because we also have to do the per-rectal examination to see that if the patient says that it's more in the back, so then we can know that whether these are the puborectalis, pubococcygeus, or the bulbo cavernous, or all the pelvic floor muscles which are taut, and they can be, we'll send them, we'll start some medications, because for the normal analgesics, like any.
So basically, an understanding of this, the examination can give you details on how you can go with the physical therapy.
Yes.
What I wanted to point out, that these
because there's a tenderness, you can write it in your, you can show it with a diagrammatically where exactly is the tenderness, and then they can send them to the therapist, and they can do some internal massages. That is the main idea, along with some physical therapy.
So as we narrowed down and we realize that we are dealing with a woman who has 2 coexisting concurrent diseases that she's been inflicted. So we need to now realize that she also has the element of interstitial cystitis bladder pain. And interstitial cystitis bladder pain, just like chronic pelvic pain, is a debilitating condition. And you need to do a stepwise approach to these patients very empathetically, and you need to educate the patient. So there are 4 to 5 lines. And I think as a gynecologist, if we are able to help with the first 3 to 4 line of treatment, I think that will help us to understand and to identify these patients, because these patients probably come to us, and because we do not know about this condition and the awareness is poor, the treatment profile given to them may not give them any success. So I think today, as the GIPS Society is working in India to just give an awareness about this condition, that all chronic pelvic pain need not be gynecological ailment. It has to have other elements, and we need to think out of the box. We need to go with the other specialty and take help from them. So starting with ICBPS, there is the first line. It's always a conservative line where we need to know that the patient has to be educated. The patient's food profile has to be probed into. We have to teach them what are the diet restrictions that they need to do. Even an overactive bladder, I think we always look into the fluid intake that they take. Are they taking any irritants? How they can stop their coffee intake? How they can stop smoking? How, as a stress management team, we can help them in relaxation techniques. So these all have to be at the level of the gynecologist. I think these are basic things that we as gynecologists can work out with our patient. Analgesia, I think nobody will immediately send the patient to Dr. Amita at the first meeting. I think it is always going to be a plain analgesic treatment and the coping technique. Dr. Meera, do you agree with me at this point?
I do. And I like that for previous slide where it said realistic goals. Now we'll have to clearly explain at the very outset, though she might have seen us as the nth person. It's not like fever where you take a paracetamol and everything disappears. It is an up and down flares and remission. So we cannot cure, we can control the disease. And if there are triggers like an asthmatic who eats an ice cream and gets an attack, she should refrain from taking those substances which can trigger and take it in moderation. So her contribution to the well-being is also very much important and should be emphasized.
So very well said, Dr. Meera. We have to educate them and let them know that self-help is very important. So we have to train them with coping strategies. I think there are a lot of modules now. There is one which is called the fear avoidance module, which deals with fear of pain, anxiety, and these patients usually catastrophize their pain. So we have to tell them to overcome these pains by their own self and how we can educate them. But in case we fail with this, the patient has been given all the 3 lines and are not able, how do we then go forward with the second line of treatment is the physical therapist. therapist, where we actually want them to relax because their pelvic floor muscles are always in a hypertonic condition. I think Dr. Navita, this is where your help comes.
In fact,
Right?
Dr. Navita and like Navita, people can see them at the first consult as well if that luxury is available, because of the chronicity and the duration has just elapsed. So it will help us control the pain in the first sitting itself and give us ideas of how the pain is triggered as well.
Absolutely. So, Dr. Navita, in a very short nutshell, can you say about the physical therapy? Let's not go into that. We are overshooting the time.
Yeah. So yeah, the main thing is if we identify the trigger points, which are the bands, myofascial bands, and we can send them to the physical therapist to release the bands, which is called as myofascial release. And you can tell them which muscles are involved, or you can just guide them with a diagrammatic, and you can talk to them, because if we have that facility, like in my case, we have everything under one roof. We tell them, and there's something called as, not only this, we can tell them to do some tense of the pelvic floor muscle. So that will again help them in resolving, or to some extent, their pain. And also we have to tell them, because there's already spasm of the pelvic floor, we have to tell them to avoid pelvic floor strengthening, but tell them how to relax. So we'll have to tell the physical therapist.
Dr. Namita, I would like you to just point out, when you speak about muscular trigger points, so what are the modules that you use when you speak about the trigger points?
Trigger points, like I would means if patient are not getting better with a myofascial release, which can be Thiel's massage, or it can be a pressure, so which the therapist will decide. And internal massages are also very important. And once then you can tell your therapist to teach the patient, they can do themselves self-care, as you have been talking about the self-care of their own trigger points. They can do internal massages as well as external massages. They can do on their own. It's just like putting a pressure on that trigger and then relieving, immediately releasing that. And if not, then we can go and do some myofascial injections with ultrasound.
What normally is been told is, whenever there is a patient with a pelvic floor pain, it's usually because of the spasm. It could be a trigger where these women who've had endometriosis or who have had surgeries, they usually tend to have a spasm in the muscle. They have a shortening and a spasm, and these trigger points then get completely into the floor. So you get a complete trigger point, and I think that is where you need to, your Thiel's massage and all works wonderful at that point. And teaching her to do the same thing can make it more easy for her, rather than every time coming to the therapist. Again, as a gynecologist, we are so used to having a pelvic floor dysfunction. We have prolapses, and we always keep telling them to strengthen their exercise. But what we need to understand at this point is, in ICBPS patients, these patients already have an hypertonic muscle. So please do not tell them to do the Kegels. There are a lot of relaxation methods and exercises, which probably in our next webinar, we will look and we will talk about it. We must avoid Kegels exercise for these patients. The second line is when you give them normal non-steroidal anti-inflammatory and you do not get, this is where I think Dr. Navita also has been given. We can go into tricyclic, amitriptyline can be given, hydroxyzine can be given because of the mast cell involvement, pentozan, which acts as a protection for the gag layer. All these treatments can be done. Along with that, later on, if the patient is still not comfortable, there has been treatment with intravesical installation. Dr. Meera, can you quickly, in a very short way, tell us the intravesical
I just want to interrupt. I think that these things have been covered by Dr.
Okay. Yeah,
So,
I think Dr. Khullar did mention about the cocktail regime, and we'll go with that. After the second line, if the patient is still not comfortable, I think this is where the role of cystoscopy with low pressure hydrodistension will come in. And I think we've already taken it from Dr. Amita. Dr. Meera, in a case of ICBPS, how would you do a cystoscopy?
No, the cystoscopy should be under anesthesia.
Absolutely.
Because we have done our examination. These patients will not tolerate a local anesthetic outpatient cystoscopy. And the idea is with the therapeutic intent, not just a diagnostic aspect. So it has to be done under anesthesia and usual filling. And it is not the first look cystoscopy which will give us the probable outlook of what the stage of the or the grade of the ICBPS is. So we can diagnose between two phenotypic presentation of whether a Hunner's lesion is there or not. For benefit of everybody, I'm sure you would have listened to this. Hunner's lesions are linear ulcerations with breakages and hyperemia around the edges. They are star-shaped or stellate scars, basically. And you can see the mucosa breaking up when you deflate the bladder. So you inflate the bladder, deflate, and go in with the cystoscope. You will be seeing these hemorrhages, which can be blotches, or you can be seeing these linear mucosal breakages or even Hunner's lesion. Hunner's lesion, you can fulgurate them at the same time. You can excise them at the same time, and you do a low pressure hydrodistension, which will improve the symptoms. And maybe at a second sitting, you can do an intravesical installation or the next day before discharge.
So I think, Dr. Meera, you've said it all. It always should be done under anesthesia, general anesthesia, low pressure, and it should be therapeutic at the same time. So you should not go with the intention of only diagnosis. It should be therapeutic, and there are two phenotypes. We have to understand that first, it was always considered that Hunner's lesion was the criteria for ICBPS. It is no more like that. It is only seen in 4% of the patients with IC, but whoever has the Hunner's lesion, they usually have their symptoms exaggerated, and fulguration of the Hunner's lesion gives them a lot of relief.
It cures them. In fact, it's like magic.
Absolutely, absolutely. So now we come to the fourth line. I think Dr. Amita has covered up the botulinum part of it. So I would not go to the detail, but I think we as gynecologists reaching up to the fourth line is good enough, because we have to realize that we have to think beyond the uterus and the adnexa. We have to think beyond vulvodynia and all, and we have to think of the structures that are involved in the pelvis who are neighboring us, and we could have a lot of pelvic crosstalk, lot of sensitization is what Dr. Meera also pointed out, and we need to work on that. There is neuromodulation that can help ICBPS patient, but ICBPS patient also has multifactorial conditions. So pelvic floor is very important when we deal with these kind of patients. The fifth line is of course with oral cyclos.
Can I interrupt? I think we just give a take-home message that once we are actually diagnosing these patients at early stage, more than 90% of patients doesn't require these kinds of higher treatments. They can be well treated on early.
Absolutely.
So that's the take-home message. We
don't only take-home message, Dr. Amita, is we must learn to diagnose this patient, and awareness is very, very important. That if we have any patient who comes with refractoriness to endometriotic pain or even for overactive bladder, we must think of ICBPS. We have to rule out this, because if we do not, then the delayed diagnosis lands them up in the last stage and the last resort of cystoplasty, cystectomy, and urinary diversion. I think we should seldom get into this kind of condition.
No, it's very important, like Dr. Amita and yourself mentioned. It should be diagnosed early, and what the mind does not know, the eyes do not see.
Absolutely.
So it's a high degree of suspicion, understanding it's a coexisting disorder along with endometriosis, and treating before fibrosis of the bladder sets in. Once the fibrosis of the bladder sets in, the woman goes through hell, a lot of problems in life, and they are young, and it's not fair on them to go through such hell day in and day out. So it's catching them early, making a difference to the pain, and thereby making a difference to the quality and the progression of the disease itself.
Absolutely.
Yeah, so if the bladder capacity is less than 150, it's the bladder is contracted.
It's contracted.
Then probably the botulinum toxin, nothing will help.
Nothing will work.
So that's the end stage, and then you have to actually increase the capacity by doing.
We should not allow our women to go there.
So definitely, that's the reason I said that the dilemma is, it's challenging to all of us. Sometimes I'm sure you and Dr. Amita, being a urogynecologist, may have missed it, and probably seeing the patient in your second and third visit have realized that we are not dealing with the right thing, and we need to work beyond that. So I think
if we all in FEPPA and GIBS do whatever we are doing, the previous slide would not exist.
Absolutely. Perfect. So when is the time to refer is that we have to realize it's never a one-man show. It is always a team. And if you take the right history and we know that there is no gynecological component or there are other organs involvement, please feel free to take help of your colleagues at this point of time. And we have enough and more colleagues around us who are ready to help us. We've seen in our COVID times, all of them are ready to help. It's just that we need to ask.
So that's I want
to say across borders, use your smartphones. You can even record what's happening at Cystoscopy, ask the experts, get the job done.
That's the same thing I want to say, Dr. Meera, that please put your queries at our groups event. It's not so easy. Be a member
your smartphone, get the permission of the patient beforehand. Get the smartphone.
You don't need to show the video. You can keep your queries.
Yeah, you can keep your queries. If you're in doubt whether this is what does Hannah's lesion look like. So I know it's difficult sometimes. Use the expertise around.
I think, Dr. Meera, today's day and time with the internet on and the smartphones,
that's the best way to network.
These are the modalities that when I said multimodal, I think this is where we need to work on.
Absolutely.
Okay, we need to get tech savvy and make use of it. So Dr. Praful, Dr. Saral, I would like you all to just give a take-home message with regard to this patient where we've seen this patient in the initial stage and we thought it was endometriosis. And as we went with the history, with the physical examination and the investigation, we realized that she was not just dealing with endometriosis, she was also dealing with another condition which the awareness in our country is still not so much. So the awareness, as Dr. Meera pointed out, that mind has to know what the eye see is very important. So a take-home message from Dr. Praful. I have the golden rules. I think absolutely the adequate time to scrutinize is needed. A good rapport with the patient is all that is needed in the first visit of the patient because she's visited n number of doctors. She's got no relief. The patient should feel that she has a story and her story has been heard and we believe in it. And we need to initially assess this patient because she's been with so many people. We need to go thoroughly and we need not ask her to do the same investigation which she's probably done n number of times. And we need to think beyond our gynecological outlook. And we need to partner with our colleagues who are in other specialty. And in India, psychological counseling, CBT are still not a big thing. So we need to also start reading and about how to counsel such patients. It's very, very, very important. As much as the physical organic cause is there, the psychosocial element is a part of the treatment and we must be aware of this. So let us end this session by saying that, let's not lose such patients or delay diagnosis because of not being aware of such conditions, and let us partner with our colleagues and make these women feel that they were heard and they were treated well. I don't know whether we have more time to take the other case, but this was a case that I would like to just focus on. This is a patient who's undergone hysterectomy and she was complaining of vulvodynia.
I think Dr. Vidya will keep this case for the next session.
Yeah, I think let's end it up. Patients don't really come to us because they are in pain. They come to us because they are suffering is what we need to understand. Do we have any questions?
The one thing I would like to emphasize is the triangular love between bowel, brain, and bladder. Because many patients ask me if my bowel is upset, why do I have a trigger? It's because of this triangulation and the crosstalk. That has to be really emphasized as patient education.
So pelvic crosstalk is something we must point out to the patient and we must let them know that we have the neural pathway which is common to all three organs that are situated in the pelvis. We have the musculoskeletal system along with the bony tissue. Everything matters. When we deal with the pelvis and when we deal with pelvic health, we must know all this in details. Dr. Amita, any questions at this point?
I think I have interrupted you in between to answer a few queries I have seen at that time, but right now I don't have. I think you covered all the things so elaborately and so nicely that there are no questions.
Yeah, I think Dr. Surendra Paul wanted to do multidisciplinary therapy. Yes, in these conditions, I think any condition of CPP, there has to be a multidisciplinary role. It cannot be a one-man show. It cannot be one specialty show.
It's rather his comment that yes, it's necessary. So everybody is agreeing with whatever you have said, because that's that should be the approach. And I think you did an excellent job.
Yeah, I think today we covered up the chronic pelvic pain. I think Dr. Vikram elaborated very well. The focus was more on bladder with the SUI treatment and the cystoscopy. So today was more of pelvic pain. Focus on bladder is what we should have labeled this session. I think we covered up. I must thank Dr. Nagendra, Dr. Jagruti for their spontaneous, enthusiastic, short notice webinar. They've been really very supportive in this. So thank you so much. Thank you, Dr. Meera, for the last minute invite. And she said, yes, I will be there. No worries. Thank you, Dr. Praful, Dr. Saral.
I will ask Vidya to just stop your share screening so that we can have a kind of...
Absolutely. Sorry. I'm so sorry about this. I think you get completely involved with this.
Yeah.
Thank you, Dr. Vidya, for excellent coverage. I just wanted to add one thing, that referring to a psychiatrist quite often I find counterproductive. To suggest a woman who is suffering that it is all in your mind, the psychiatrist is still a taboo. When you refer to a psychiatrist, patient thinks that nothing more can be done about her pain and it is a psychological case. So I think we should be familiar with the simple tricyclic antidepressants and certain antidepressants, and counseling we can do like every other psychologist. It's only about requiring some more time. But referring to psychiatrist early in the when you don't find anything, referring to a psychiatrist, I find it very counterproductive.
I'll interrupt you here. Actually, with these kind of patients, sometimes you have realized that they've already been to a psychiatrist before they've reached you again.
Exactly. So referring them to a psychiatrist, they lose their trust on you.
Absolutely.
So, Dr. Praful, the thing is that what is the requirement? You can't send these patients to any general psychiatrist. There should be a team involved who can understand that it's the chronic pelvic pain. They have to treat it differently. If they are just doing the treatment for anxiety and depression or something like that, it's not going to help. That is the difference. So that's the idea, that we should actually create a team. Once we are dealing with these patients, we must know those psychiatrists, those physiatrists who can actually correctly point the problem and can give a targeted treatment rather than doing a general kind of treatment, because it happens even with physiotherapists. You are sending patient and they are treating them with by making them learn Kegels, which are actually contraindicated. So that's the thing. That's the point. Actually,
Dr. Amita rightly said, we need to know that these physiotherapists are trained for pelvic floor dysfunction. They are not just normal physiotherapists. And as Dr. Praful, you said it very nicely, we cannot send them to psychiatrists. We have to send them to a psychological counselor who knows these kind of conditions. So what you pointed out, it is a taboo and it will be always there. The patient will think that I'm definitely having some mental issue, which is not what we want to address.
And her family members, especially her spouse, is already telling her that it is all in your mind.
Yes,
I'm telling you, it is all in your mind.
That's very true. It happens. It's not about the doctor. Even the doctor thinks sometimes that it is everything is
Dr. Tarlika wants to say a word. Dr. Tarlika, we would like to hear something from you.
She's already depressed, already depressed lady is coming to you after consultation with so many people, spending so much money, so many laparoscopy, cystoscopy done, and then she comes to us. So we have to sympathize with her and treat conservatively first.
So I think it's time, Dr. Tarlika, that we also learn some techniques of counseling such patients. So what I wanted to say, Dr. Praful, that we need not send these patients to a psychologist immediately, but we can do some kind of counseling at our end.
What I'm saying, that we can be a good counselor ourselves only if we have enough time.
Yeah, so that's the thing. I think clinic for chronic pelvic pain should have a time limit of larger than the time limit.
Like the homeopaths.
There was an excellent moderator. She drew the whole thing. She completed. She covered all the aspects, and she extracted what she wanted from all the panelists. Dr. Vidya, you were excellent.
The clinical consultation should be longer than the duration of the webinar.
Absolutely.
Thanks a lot, because we all gynecologists are psychologists, psychotherapists rather, not psychiatrists.
I think we are the major point of contact, doctor, and I think even for their normal COVID symptoms also they have called us. So
exactly. We are getting so many calls every day, friends, patients and relatives and who is not.
That's all the matter of trust, ma'am. That's the matter of trust.
So I think
maintain that by just listening.
So let's close the session. I think we must thank all the panelists. And I think Doctor, who is the one who's going to give the vote of thanks?
Thank you,
Dr. Kajal.
Thank you all for the wonderful session and the wonderful panel discussion. Now it's my privilege to introduce Dr. Kajal Mangukia. She is a secretary, SOGS 2021-2022. She is a consultant gynecologist and obstetrician and IVF specialist and medical director at Orchid Hospital and IVF Center at Vesu and Lal Darwaja, Surat. She has been also awarded Nari Samman Award 2017 from Surat Municipal Corporation, and she is a very good friend of mine. Over to you, Dr. Kajal Mangukia.
Thank you, Dr. Purvi. So here I want to start the vote of thanks with one quote, that alone you can do little and together we can do so much. So this is a live example of it. So with FEPPA and Urogyne committee of FOGSI. So thank you, Dr. Amita Jain ma'am, Dr. Vidya, Dr. Narendra Vaghela sir, who all have supported us, and we have arranged this webinar. So it is a great thanks to and heartfelt thanks to our chief guest, Dr. Tarlika Gokani madam, our speaker, Dr. Vikram sir, for sparing his precious time and making this webinar a most informative, educational and interactive one. Thank you, Dr. J.B. Sharma sir, and a special thanks to Dr. Amita Jain madam for her excellent videos, ma'am. It was too good.
Absolutely, absolutely. That goes without saying.
That should be clapped for us.
I'm thankful to all of you that at such a short notice things were arranged, and it's all the enthu, it's a teamwork. It's enthu which
I must say that Surat Obs and Gynae Society were really very enthusiastic. I must say that.
Thank you, thank you, thank you.
Thank you all the chairpersons, Dr. Ranjana Sharma, Dr. Ruta Gokani, Dr. Sandhya Chhasatiya madam, and all the esteemed panelists from Surat, Dr. Praful Doshi sir, Dr. Tejal Shah, Dr. Saral Bhatia, from Delhi, Dr. Ranjana Sharma, from Mumbai, Dr. Navita Purohit, and from Chennai, Dr. Meera Raghavan. Thank you, Chesta and Dipti, for the technical support and as a coordinator also. And thank you, Dr. Purvi, for being with me. And our upcoming program is a mega event, that is a laughter challenge.
Please thank Dr. Vidya profusely.
Yeah, our moderator, Dr. Vidya also. And our upcoming program is a mega event, that is a laughter challenge show on 23rd of May in association with IMA Menopause Society, Surat Consultant Association and Surat Surgeon Association. So thank you everyone. And this was our 4th CME program in a span of 1 month. We got installed last month.
Kudos to Dr. Jagruti. And I think now I know that when we deal with chronic pelvic pain, we look at not just the physical part, but even the social aspects, which I think your Gynae Society is very good with.
Thank you, everyone.
I think before ending, Dr. Kajal, one more thing is FEPPA is just a new association. We would like you all to be a part of the association. And if any of you all have any story which is unusual for the chronic pelvic pain with different symptoms or anything, please write to us so that we can get into that. We can discuss these cases in a forum like this. So it helps us to make the awareness program more better and more knowledgeable.
Sure.
So we will have ongoing panel discussion in our group.
Yes. Thank you so much. Yeah.
This is not the end. This is just the beginning of our association. and we'll like to continue our association with
Thank
FEPPA.
you so much.
We will have many more programs with you all, ma'am.
Thank you so much. Thank you so much.
Thank you, everyone.
I think
Thank you,
everyone. We need
to everyone.
Yes.
Bye.
Thank you, ma'am. Thank you all.
Bye.